morning everyone. I, Dr. Ashish Chandra, today welcome you all to the 16th World Dental Sciences and Oral Health Conference and PFA Convocation and Award Ceremony in this beautiful city of Colombo, Sri Lanka. Today we are honored to present an esteemed lineup of lectures by renowned expert speakers followed by fellowship, convocation, awards and valedictory. For the first lecture of today, I would like to invite Dr. Professor Johnson Raja James, MDS, MS, PhD, Diplomate, ICOI. We welcome you, sir.
Very good morning. More like a breakfast meeting, and nice to see some senior members in the crowd. So glad to be in Sri Lanka for I don't know fourth or fifth time, and I'm here on the invite of the organizers and my good friends Udayan, Kriti, Lanka, and all known people in Sri Lanka. So though we are running late by half an hour, I thought we'll just next half an hour. Rather than I'm not here to teach you about zygomatic implants and all that stuff, but how we as dentists can do a procedure and how it can be life-changing for our patients. Life-changing in the sense even a good orthodontic treatment, a single tooth replacement, and a lot of things can go a long way in improving the confidence and lifestyle of our patients. But what you're about to see the next few minutes is about little more complicated rehabilitations that we take forward, where people have no other choices. People are roaming around, even still roaming around, seeking solutions. And whatever you see for the next half an hour might be a change for one of your patients too. I'm Dr. Johnson. I am a more of an implant rehabilitation person. We're based in Chennai. We have a presence in other countries also, and all that happened because of our exposure to advanced implantology, especially zygomatic implants. So I'm here to present on some good cases and how we can take this forward as life-changing concepts for our people who really trust on us. You know, when patients come to us, they think at one level, when you become a referral center, when they've gone to multiple places and they haven't got the right solution, they think you're the last resort. And when you get such patients, you have to give them things that they're confident about, you're also confident about, and it goes a long way. So zygomatic implants, as you know, are used for restoration of the atrophic maxilla, and more so in maxillectomy defects in onco patients, and in the recent onslaught of COVID. You all know how India especially became an epidemic center for the mucormycosis massacre, and a lot of patients came up with even learned patients, educated patients, doctors, dentists developed mucor, and we ended up with a lot of patients who went on to rehabilitate with zygomatic implants. Okay. Alright, so when we talk about quality of life, what is the lifestyle index? There are some indices where how we define what the quality of life is. So when we have patients with these kind of advanced defect, anything from a simple smile to a chewing, even curd rice or something becomes a very big matter for them, right? So the restorations we are about to see are aimed at restoring such a quality of life. So these are two kind of options you will see when you think about zygomatic implants. The first one is all-on-4 with zygoma, and what you see on the next slide is about the quad zygoma. The quad zygoma, this selection of implants is based on the Bedrosian classification, as you know, adequate bone in zone 1, 2 or 3. So these cases we will choose when we have adequate bone in zone 2 and 3. Inadequate bone in zone 2 and 3, where there is bone only in the premaxilla, whereas in the other case, the quad zygoma will use when there is total loss of bone in the maxilla, and we even get loss of pterygoid bone, only bone present zygoma, especially in the maxillectomy defect. You have the total bone is lost and you have bone only in the zygoma. The zygoma is actually kind of a resilient bone. All the cases that we had of these mucor cases, the onco cases, surprisingly the zygomatic bone was left intact. So that is when the zygomatic implant is a more suitable orthodontic management cases. So the first case you see over here is a 35-year-old female, an entrepreneur and CEO of a big company, but on dentures for at least 15 years. Very young age, her teeth were extracted due to reasons unknown, and multiple clinics where they told that implants can't be done for you. And we went on, so you can see the lower dentition is intact, especially implant rehabilitation in patients who have a lower dentition intact. It's more of a challenge because of how to get a proper occlusion for them. So we went on to plan the implants for her. This is the armamentarium. All these cases are done under local anesthesia. The flap is raised. Okay, and we go on to. We usually, when we go to these advanced cases, we try to do them guided, because a quad has to be very precisely placed, especially with good BIC and proper trajectory. Okay, so these are the, as you see over here, these are the, do we have a pointer here? Okay, this is a pointer, okay, yeah, okay, correct. So this is the positioning of the guide, and this is how it looks like. Now when you raise a flap, we have to prepare trajectory for these two slots over there. This is the extra-master technique of placing zygomatic implants. And first thing we do is to gain entry into the zygoma. We make a position of point B, exactly where we need to enter into the zygomatic bone. Okay, and then we slowly angulate towards the crest, where we now connect the point A and point B. Okay, and then we go on to prepare a guide path for entering into the zygomatic bone. That is the first zygoma, and that's the second zygoma. Now this picture I wanted to watch very closely. You can see here, now this is my the precise drilling of a quad zygoma, where you can see 2 points. This is entering the zygomatic bone of the distal implant, and this is the mesial implant, where now we'll go on to go for the quad piece. Okay, so more clear visibility, and then the trajectory is set and the two guide paths are prepared. Then we go on to measure the length of the ideal zygomatic implant. We have the depth gauge, where we move in to see what is the length of the implant we can place. So this is 35, 40, 45. So from over here, 42.5 is the choice of implant we have done. You can see in this picture how it looks like. This is how a quad zygoma is positioned. The parallelism is very important, because we don't want the implants to collide as you go towards the apex. Okay, so the trajectory is done, the guide paths are prepared, yes, and two implants are selected. This is how it looks like. So this is the first zygoma being placed, and you can see the angulations, the trajectory, and see my thumb over here is very important to make sure that my implant is precisely at the cheekbone. It's not angled towards the eye or towards the infratemporal fossa. It's very important that we have an ideal trajectory for placement. The second implant in position. Okay, there are a lot of fine things over here which cannot talk in a 30 minutes lecture. So this we'll show pictures. Of course, after this we are here for networking. We can discuss how it is done, what is done, and all those things we can discuss later on. Right. So that's the implant being placed, and we have two implants in position, all into local anesthesia. A matter of the entire procedure for a segment will take you maximum 30 to 40 minutes to do. Provided you do a proper planning, the guide is set, the implants are ready, the armamentarium is set. Okay, and what we do is we go on to cover it with the PFP, the recharged fat lobes, so that to get additional keratinoid gingiva onto the buccal surface. So that's the PFP being sutured with the PTFE. And we went on, go on to place the multi-units. Now, if you have a prosthodontist in the group, you will know how significant it is to get such positioning of multi-units which are adequately parallel. So we have placed two multi-units. One is both are 45 degrees, which gets good parallelism for our path of insertion and removal. So that's our final position. You can see the implants in place, the multi-units placed, and we also have the BFP to get good attached gingiva onto the buccal surface. So a little bit of blue M for better healing, and that's how it is done. We'll go on to the right side. the flap being raised. So that's how a guide looks like. This is a positional guide. It's not a fully guided surgery. This is a positional guide where we have the trajectory set. Same sequence now. Once see zygomatic implants, the sequence is much lesser than what you do for a root canal. You have point bar, then you have the guide path drills, then the twist drills. That's it. We have only 2 or 3 drills to be used in the entire procedure. Okay, so the guides in position, drilling done, same, the depth measurement, the implant in position, implant placement, yeah, PFP, and suturing done. Now, after all the surgical procedure is done, this is what I want you to see. Now, once we get a case like this to your clinic, now this is a typical all-on-4. So, a patient comes to your practice and then you decide what kind of fixture is required, suitable to that patient in that condition. Now, if you give this to a restorative dentist, he doesn't worry about it's a zygomatic implant or a nasal implant or a pterygoid. What you see here is an all-on-4. What lies beneath actually doesn't matter. Okay, this is how we should be handing it over to a restorative dentist. A good AP spread, good parallelism, and sufficient attached gingiva on the buccal. This goes on to now we can treat it like a regular all-on-4. You don't have to think of it as like a quad zygoma or anything very complicated. It just feels like a regular all-on-4 for restoration. Okay, so healing caps in position. So same day we take the transfers. Okay, conventional implantology, transfers, take impressions, and that's what we have. And this comes in at the end of maybe 3 to 4 days. You can see the quad in position. You can see the distal implant almost in the region of 6. You can appreciate that. We have the distal zygoma in region of the first molar. Now we can go on for restoration here without a cantilever. When you think of zygomatic, when you can position it in the region of the first molar, it's very, very good, because now you don't have to give a 7 cantilever, which can be more detrimental to the processes, right? And then placing the zygomatic with a tooth in position. Sometimes, when you talk about full mouth rehab, we tell patients sometimes don't want to extract the good teeth we have. For simple reason that something of theirs remains over there, rather than go for, if you have patients coming to you for full mouth rehab, if you can tell them, these 2 teeth I can save, they're very happy. You would have experienced that. These 2 teeth, then doctor, no doctor, I went to that clinic, they told total extraction. I said, it's okay, the 2 teeth I can save for you. Even if you leave that 2 teeth, psychologically they have a very strong, good feel for them. Yeah. So the next picture is what I want to see, that forms the crux of this lecture. The next 3 cases you will see is same. What do you see the difference between this picture and this picture and this picture? Can you see the change in the way she smiles? What I have observed in these terminally rehabilitated, debilitated patients, they don't look at the camera. When you take profile pictures, the common factor, I'll show you the next 3 cases, common factor is they don't face the camera, they don't want to look at the camera, and they don't smile. But once you go in for these rehabilitations, you can see the broad, I didn't tell her to do a broad smile, I just told her to smile. They give her a very broad smile. And you have a profile all built up, and now these cases are at least 3 years old, and they have become like family. Once you go on to do these things, they come with their husband, their family, they bring sweets for Diwali, and then they ask you for dinner. That's how the rapport you develop with such kind of patients. Okay, so this is a case of routine cases we get. So we'll see some more advanced cases. Now, those of you in the crowd who think zygomatic implants are complicated, and once you get trained in zygomatic, it's very, very simple, straightforward procedure. Very good success rate of some literature has reported up to 96 to 98, even 100% success rate when you think of zygomatic implants. So the next procedure we'll see is about restoration of maxillectomy defects, especially in mucor cases and onco cases. And again, the challenge here lies in these kind of cases where you have a complete, stable, strong mandibular dentition and a totally atrophic maxilla with no nil alveolar bone, only zygomatic to hold on to. Now, what is the challenge we face over here? This is the huge force, the occlusal force that you're going to face. Once you travel into implants, you will know the success of implantology is in occlusion. It is not on placing a super duper implant, the most expensive implant, who put the most expensive graft, the most senior dentist, doesn't matter actually. What matters in long-term success of implants is occlusion and how the patient bites. It's the single most factor I have seen which contributes to success of implantology. Yeah. So here, what I was happy about is these two teeth. These two teeth are the saving grace. Okay, if I tell we'll extract these two, then we are done. So this helps me to maintain the VD, and I can give the primary contacts on the molars, and because now we'll be having zygomatic over here, which will be long cantilevers. Only the zygoma is going to hold on. It will be the 13 millimeters which is going to anchor your processes, whereas you have the entire cantilever staying outside the bone. Okay. So again, fortunately, the patient didn't have any oral dehiscence. The tissue dehiscence was not there. It's completely covered. And this is how a 3D model looks like. You can see the entire maxilla done over here, but what remains is the zygomatic bone on the first quadrant. So this is the planning that was done, and those of you or your friends who are involved in this kind of rehabilitation, the success lies in keeping less height of implant outside the bone. That means we don't want a vertical cantilever over here. We want to keep it as close to the bone as possible, just outside the soft tissue. So this is the planning, the guides, and that's how the patient looks like. Typically they have a caved in upper lip, no profile, and very difficult to pronounce, talk, smile. Okay, so you can see when I raise the flap, this is all the zygoma that is a little bit less clarity over here, but it's okay. This is all the zygoma that remains for the patient. Okay, and the guides in position. This is something that we use for such advanced cases called the zygo versa burst for more precise drilling and the preservation of bone, more like your densa, but here it doesn't really, just expands. So this is what we use for this patient, and went on to the same sequence of drilling and positioning. And the right side, you can see how precise it has to be. You can see this is the only zygomatic bone available, and this is the two drills we have placed into the bone. Okay. Okay. So this is post healing. We have 3 zygomas on the right and 2 on the left, and yeah, this is done. Okay, sorry. Okay, so this is the implants being placed. That photo came in between. This is the implants being placed, and again, very important is the positioning of the multi-units. Ultimately, to be restrictive, you can place the most skilled zygomatic implants, but if you don't do a proper restoration, it doesn't make sense. So the multi-units in position, the right side, 2 zygomatic, and yeah. So this is the final picture for this patient, 3 on the right and 2 on the left, and that's the post-op CBCT, how it looks like, how it looks like in the scan. You can see it more precisely. You can see it's very important that we engage the outer cortex. You can see all the outer cortex being engaged over there. Very important that we engage the outer cortex. And that's the final picture. Once it is done, you can see good healing, tissue closure, the bite restoration, and that's the wax trial and the final processes, intaglio surface, and that's the fixed screw retain process we are given to him because there was no tissue dehiscence for the patient. Yeah, and that's the final picture, the screw retain process, and that is how he was. I don't have a profile pic, and this is how he was. Actually, this is him talking, and you can see the confidence which he can speak, smile, talk, bite, chew. And that's what we could achieve. This patient, this video was taken after 1 year, and he's a vegetable vendor. He runs a shop. So previously he had complaints that he could not talk to his customers. It's not about smiling. He couldn't do business. His business was crippled. He could not do anything. He had to We had to have assistants sit with him to tell about the price. And then when he spoke, his complaint was the saliva was spattering. So people didn't like come to him or talk to him. Whereas a simple restoration like this helps to, restore his quality of life. We'll go on to the last case. Okay. Right. And this again is a doctor, a patient who had handled a medical doctor who ended up with mucor, and again restoration for him. And this is how we could do, but this is a patient with a dehiscence. He had a rectal dehiscence, so we did not go for a fixed processes. We went in for a obturator kind of process, semi-fixed kind of process. That's how it looks like. You can see here. So this is snap-on process, same kind. Previously we had a fixed process. This is more like a snap-on process, and that's the end of restoration for the patient. So different scenarios and how it is managed. Finally, a case we did in Bangalore, again a mucor patient, where this is the maxilla was totally destroyed. And see, now I told you right how the patient looks when they take the first picture and the restoration done. And this is the final picture. Typical. I think we can do a survey of how patients see here the first picture where they don't look at the camera, they are down, the levels are down, whereas they go on to the final restorative picture, they are more normal. They can lead a more normal kind of life. Okay, so zygomatic implants. So I think my point is clear. I have people come to me. People come to me asking, can I put my daughter and son into dentistry? And then I spoke a lot of people. They say dentistry has no scope. There are 10 dentists in every signal. And when I tell them, see, once you develop skills, it's a journey. It's not like you finish your PDS and you start making 1 crore a month the next day. It's a journey, and then you have to have something that is different in you. You cannot be just among the crowd and doing regular extractions and fillings. And there is a huge scope of expansions, huge scope of development, growth, and I'm sure there are stalwarts sitting in the crowd who will agree with me on that. And I feel it's more of us to take it forward and tell them that dentistry is an amazing profession. We can be equally instruments of God in touching people's life and giving them a good quality of life. And at the same time, for us also, it's an economically rewarding profession, morally rewarding profession, and a lot to happen in dentistry. And it's conferences like these that get together good minds and take things forward. Okay, thank you. So, zygomatic implants, multiple configurations, right? And this is a question statement by the American College of Prosthodontists to restore the quality of life and give patient an expedited and predictive treatment option, especially in severely challenged cases. That is me. So we're welcome to connect at any point of time. And with the permission of the chair, I'd also like to talk something about about something that's happening with us. This is a conference that's coming up in August. It's the first global dental implant summit happening in Chennai, and done by a big crowd, big team of implantologists. Okay, and that's those of you who want to take a snap. This is a group that you can all join to get updates, and otherwise you can just type IAOI. This is a conference, of course. The Dr. Gutmann and all of them will be a part of it, and we are trying to strike an MOU with the Sri Lankan Implant Association also to. The next thing for us to do is, now this is a big team here. Now we have to form a bigger network among Malaysia, Bangladesh. You see the Bremtech happened just under our Prime Minister. Bangladesh, Malaysia, Thailand, Nepal. I think we all have similar practices. We all have similar patients, similar profiles, similar oral profiles, similar patient profiles. I think next is to all of us to connect and develop common good practice systems and interact, and I'm sure more such things will come. Thank you very much. Thank you for the opportunity. don't know if you have time for questions.
Lecture. And now I'd like to invite Dr. Anmol Bagaria, the CEO of Cynodent and PFA Section Chair, Section at Large PFA Asia region countries, and Dr. Ashish Chandra, Co-Director of Cynodent and PFA Co-Chair, Section at Large PFA Asia region, to bring felicitations. And Dr. Uday to felicitate the speaker. I'd like to invite Dr. Bennett Fernandez to talk about revolutionizing prevention, P4 and the ITOP paradigm. Dr. Bennett, over to you.
So, warm welcome to all the delegates who have come here. I see some stalwarts sitting there in the audience, deans. That was a fantastic lecture by Dr. Johnson, who set the ball rolling for this 16th World Dental Oral Conference along with the PFA Academy. And the topic today I'm going to be speaking on is revolutionizing prevention, P4 and the individually trained oral prophylaxis paradigm. So let's just see what that is all about. I kind of think it's something new in Sri Lanka, but it's there in India, it's there now coming up in a great way in Malaysia too, and it's there in the rest part of the world also. So I bring warm greetings from Malaysia, that's from the Faculty of Dentistry especially at Segi University, and I would like to just play a short video of my university. Start with the introduction. So basically, since it's a PFA chart, I thought it would be great if you could start with what he had to say. That little or no care as to the cleaning of the teeth, ordinarily the cause of all the diseases. Basically, he meant about the caries, the periodontitis, and all these things. And that's what destroys the God-given teeth. So we have heard this good old adage, this maxim, this proverb, whatever you may call it, prevention is better than cure, or an ounce of prevention is worth more than a pound of cure, right? So we talked about in the first lecture about all the advanced things. So I thought we'll go back to our roots, how we could take care of our God-given teeth. So in a lot of things are going on in this world of precision medicine, precision dentistry, where we are talking about giving a personalized approach. We have the P4 concept, where we talk about being predictive in our treatments, personalized, because everybody wants an individual touch to the thing, not just one size fits all, right? I mean, even when we go to wear a suit or something, we like this bespoke, we custom made it to fit our size. So that's how we should also tailor our treatments, our preventive strategies too. And definitely it involves the participation. So you may be doing these best advanced treatments, but if the patient is not going to be managing things, he's not going to be taking care of that, or he's going to take his Mercedes Benz and go on all the potholes, then you know what is going to happen. So in the same way, if he's not going to be taking care, the foundation is going to go for a 6. So, and this foundation of P4 medicine is a shift from more impulsive, just, this patient, okay, let's do the scaling. Or, there I see a caries, or let's just take my drill out and do. So it's more a shift in that paradigm, or a shift in the thought process to being more holistic in the patient care. Okay, so we call this the predictive, preventive, personalized, and participatory. Whether it's medicine, whether it's dentistry, it's the same thing which goes over. So we have this 5 4s, and in another article it was put as 5 Ps, and we even had a conference in India saying where it was included periodontology and implantology. So I mean, but the whole purpose is to cater to the individual, to cater to the patients. So why is this so important? So we know that there is a high prevalence of dental caries at 35%, and even periodontal disease, especially severe form, is at 11.2%. And this is because of this lot of microbial flora which is there, the dental plaque, what we call as the dental biofilm, which is actually in a state of eubiosis, in homeostasis. It's not that all the presence of organisms is bad, but it should be in a balanced form. Okay, so, and the gut microbiome has taught us that. Imagine that we just eliminate, when we are giving antibiotic, just eliminate, and that's the end of the story. So we are talking about being in a homeostasis rather than just complete elimination of the bacteria, the biofilm. But we know that when there is caries, when there is periodontitis, there is this dysbiotic challenge which comes about. And it's because of these numerous factors and the interplay which break down the process, especially in the interdental region. All this flora, whether it's smoking maybe, or the high sugar intake, and all these favor the process of this breakdown which happens over a period of time. So this complex biofilm, we know that it cannot be even removed by our 3-way air syringe, right? It cannot be just disrupted anyhow. You need to mechanically disrupt it, and then maybe if you want to give adjuncts, maybe that's okay, but you still need to mechanically disrupt it either by the patient or definitely by the dentist. So these unhealthy balances which may be there, this dysbiosis. So some people may think, as in the slide which I put, that within 12 hours, within quick time, it comes. So what is the necessity for me to do that? Okay. So, but that has affected the overall oral health quality of life in individuals, and numerous studies have shown this thing. And we know that the severe form is considered by Joe Freckinson as the 6th most form of periodontal. Actually, way back, the Guinness Book of World Record had put it as the #1 disease. Or rather, it was the Malayalam book Manorama also, it was there put as the most common form of disease. But still, we take it for granted, we just assume things. We are so, because our mindset is more of reparative than being preventive. So these preventive measures can be mechanical, or it can be chemotherapeutic, and definitely we have to have the good oral hygiene by doing our regular toothbrushing, interdental cleansing, to disrupt and break this biofilm. So what on earth is now this ITOP? What is this guy harping about? So individualized treatment, which I was talking about, the P4 model, is what this Czech dentist Jiří Sedlmayr way back saw when he was treating some cases, or rather his own dentist, in the University of Hamburg in Germany. So he saw that these are my future dental students, they're going to come out in this thing. So he checked their teeth, and he found that they themselves had so many caries, so many of them had bleeding gums and things like that and all. And he was really worried. I mean, these are the future, to take care of the future of the country. And they themselves, their oral hygiene is very bad. I mean, that was an eye-opener for him. And this is a beautiful setting, and if there are any students here who would love this setting, So you see there Jiri, so he's the examiner, and you see this girl doing the flossing. So any person, especially the student, will think like, oh, it's the exam and that, but on here right now, she's doing the flossing, and if she doesn't do the technique properly, the guy who's sitting there, if you observe his face, he's more tense. Because if she doesn't do it properly, he fails, not she. Meaning to say, change should be the end result of all that we learn. So we have to ask, are we changing that attitude, that mindset in our patients to help them keep their natural teeth? That is the question we have to ask ourselves, right? Because what is this philosophy all about? So in the words of G. Sedlmeier, a clean tooth cannot be sick. I mean, everybody knows that, right? I mean, even the literature says that. And the most important thing, what we have been doing, we have been learning brushing techniques through textbooks. We have numerous techniques, we have videos, AI, and then an introspection, way back down the time. How did we as dentists, periodontists, implantologists, prosthodontists, blah, blah, whatever, specialists, learn our brushing? Was it from our parents? Or just seeing something? And that maybe a wrong technique got ingrained over a period of time as habit? We didn't focus on brushing correctly, but I mean, we teach and we talk and we do, but are we telling that to our patients in the right way? Are we transferring that message across? So this whole concept of individualized trained oral prophylaxis is biofilm control, okay? And it is based on 3 pillars. Anything which you do, even your toothbrush or interdental floss, whatever, that has to be effective in destroying the biofilm. It should be acceptable by the patient. You may say you must use all these things. You must use floss. Nobody uses floss. You know that. And it should be atraumatic or non-traumatic, right? And it features on a concept called touch to teach, the famous Michelangelo painting which is there. And it's like a unique selling point where we learn these 4 things. Use of calibrated interdental brushes, we'll see about that. The correct Bass technique, I mean, you don't just say it as a Bass technique. The correct way of doing the flossing, the loop technique, and the solo or toothbrushing technique. So oral hygiene tools and techniques are learned through action, one-to-one, okay? So this is some sessions, one-to-one, the dentist, and on the other side, people learning the toothbrushing, interdental brushing, including the solo technique which G.R. Sedlmeier found out, and it is there in the 3rd edition of Practice Act. We'll see about that later too. So all these techniques are learned one-to-one, because at the end of the day, when we are so down, if somebody gives us a warm hug, it would be great, right? But imagine in that warm breath, when he comes there, he has bad breath. Oh my, right? So it's, you know, though it is this, but you feel, you know, kind of really uncomfortable. So definitely same goes for our patients too. So this is why our patients come to us. But we need to tell them that they also need to preserve their remaining teeth, not just do the treatments for that. But at the end of the day, if you haven't taught yourself, what are you going to teach others, right? I mean, so you need to practice yourself. And there are different levels, starting with the iTop Intro, which is a 1-day program, iTop Advanced, a 2-day program, and then you have iTop Crazy Buggers. Huh? And all we learn about there is how to do a good toothbrushing, how to do the right flossing, how to do a solo brushing, and of course now we talk about using the hypersonic brush, we talk about that too. Yeah, but all these things are learned on these days. And finally, every year you have to come and do a recall. So whether you're still maintaining, and most importantly, we know that whether you do not have any interdental bleeding gingiva. That means you're using the interdental brushes. Okay? And this is a session which happened very recently in Malaysia. So you can see small group sessions of learning which we are talking about. And this is my most beautiful picture. The lady in the chair there who's putting the interdental brush is my wife. And this was done last year in 2024. And I started my journey, I'll be showing, in 2019. So I'm a periodontist, she's a public health dentist, she's a PhD, she's a preventive dentist, we talk about prevention, we do blah blah, and she was wondering, what? This guy's gone berserk. But then she sees the changes. what's been happening. So imagine getting your wife there on that chair, and that's Dr. Franca from Switzerland who had come for the first course which we started on. Okay, so we did this kind of different one-to-one sessions which we do in the teaching program. So let's just start with my journey. So there is a wonderful saying in Chinese that a journey of 1,000 miles begins with a single step. So I did this single step in 2019 when I attended a conference in July. Okay, so I had a small, and that's Dr. Kishore, so I started my journey there. He was head at that time in India, and I started my journey there. So I finished my moderation of the session there in the conference, a Peria conference, and then I later went to his room and we were doing ITOP, because you have to have the interest. And then I have the advanced, but unfortunately I did my advanced, because only when you do these certifications you can go to the next, and I furthered my journey to doing this. So when I went there to the conference in 2019, I saw this picture. And I could see pictures all over, and there was only one Indian there, Dr. Kishore. And so these were all my mentors. And I thought to myself that one day even I need my picture to be there. Because that's what we are called for, right? We take the Hippocratic oath. Do no harm first. Preserve what is there first. I mean, yes, we have to treat I'm not saying that you forget about all that. Yeah. So this was another mentor of mine. Yeah, so this is from that course, my ITOP teacher, ITOP educator, and then finally I got certified as a lecturer. I did my recall when I came down for a national conference again there, because they had the office there, and 2020 COVID hit and everything went offline. And the very concept of ITOP went for a 6. But what to do? We have to still continue with the thing. So this is some trainings which I did on the bleeding on brushing using the interdental lab. Generally we use a probe, but I can tell you that you can also use interdental brushes for doing that, and your patients will be more receptive rather than. So these are the conferences which I attended online because of the COVID situation, and did some recalls, because you need to be continuously in sync to find out whether you're there. The different flossing, even when you're doing the flossing, they have a different technique. They call it as the loop or the rosary technique, which they use. And then finally we did all this, and CPS prime is for like my, where there is no interdental spaces. Yes, you can use interdental brushes. As you can see in this picture here, you can see the interdental brushes in between my teeth. And then we had I went for another educator program. And finally, yes, you can say that I was there last year when my wife did the ITOP teacher program. I was one of the lecturers there as part of the core team with communicating this message to the people, because she could also feel the difference about what it is all about. And by the way, it's not sponsored, self-sponsored. I mean, you pay for yourself. It's not like you get some freebies or something like that. It's not like that. Okay? So some people think that like Dentistry, you just take their material and then you go for their training and all that kind of stuff. No, that's not the way it works. And it's all in euros because it's Swiss. Okay? So, and that's just yesterday I just did one introductory, the first one in Malaysia. Yeah, so we are slowly starting there. Yeah, okay, and let's just talk about oral hygiene practices, because I see some prosthodontists in the audience. So they think, I am going to use zirconia. But I'm sorry to tell you, my friends, the P. gingivalis, my guy, Porphyromanus, and this was a study which was published in a very prominent journal, Dental Materials, what it can do. P. gingivalis. And now we know that P. gingivalis has already started with Alzheimer's, and now it's going to start destroying your zirconia crowns. So please, even if you have those crowns, you still need to maintain them. You have implants, you still need to maintain them. Yes, occlusion definitely is the most important, as we very beautifully said, but occlusion along with bad oral hygiene, chaos. Okay, so, but it can be because there are some patient-related factors. They are not able to use the toothbrush, they just keep using it anyhow. They spend the studies have shown 15 to 30 seconds if you really keep a timer, things like that. Okay, and the pattern may be different. Today I brush well, I have to run, I got up late, I'm late. So many kinds of things. Or it may be dentist related. Now this is in our hands, right, to educate. So are we doing that job then? Are we educating, identifying the problems? Where are the niche areas the patient is not? Or only identifying the caries there? Can we not identify that area where the patient is not keeping clean? By the way, all these things, if you're thinking is not going to bring you patients, no, my friend. It will definitely bring you patients, because all this kind of treatment has to be done on the dental chair and not as a counseling session, not on the counseling chair. So don't just, when you look in the mouth, think, where I'm going to use my burr. Okay, where it is, I can do cutting, repairing, but rather from a reparative service, talk about doing prevention. And just to share a small insight that even in Malaysia, though it is so progressed, that even there it is a very high burden, as he very again beautifully said, all these countries. That's why Modi is visiting all these countries now to strike some balance. So you can see that there is a lot of money which is involved by there is so many millions involved just to take care of, whether it's caries, whether it's all this. Because in prevention, what we are doing now, we are not just talking about patients, we are making more like sophisticated implants and this, and now you've got photogrammetry and all to make it all the more beautiful. But you're not spending that same time, effort, knowledge which was given to preserve the God-given thing. Right? And we all took the Hippocratic Oath, otherwise we wouldn't have become dentists or doctors. We all know this well. When is the right time? As Aryabhat from India, there is a number called as 0. 0 is the best time, when there is nothing at all. Not 1 is the best time. Some will say 1 is the best time to visit the dentist. No, there is a number called 0, when it is healthy. That's what we are talking about, right? So, focusing about the interdental, you can, as the French would say, is the raison d'etre of why we do what we do interdentally, because that area we know anatomically, it has the caul. If it is not, you can get the caries, also interproximal caries, you can get gingivitis, it's taken care of this. So we have these different agents, 1, 2, 3. So which do you think is the best? Okay, which do you think is the best? So you can see that there is a concave nature, and we'll see from the video, if you're thinking that floss is the answer, you can see, of course this is a diagrammatic representation, but you can see that when you're using a floss, it is not cleaning that concave area properly. It's only when you're using an interdental brush, okay, only when you're using an interdental brush you can clean. So you know that most of these hidden areas are 30 to 40% of the problems. That's where the whole problem is coming about, which is causing this. And a beautiful study which was published about using interdental brushes, and they found that, of course, you have to take the patient into consideration, not just because we are saying interdental, each and every patient is only going to give. No, if a patient is doing a good job using a dental floss, let him continue. If a patient, but definitely don't advise these wooden toothpicks, okay, so that is more detrimental, okay, there's no like the right kind of thing to, dig out those. Yeah, so in that situation you need to use the interdental brush. So how do we check the size of the brush? How do we check the size of the brush? We have this beautiful chart, and you can use this chart, and there is a calibrated probe, okay, and it is patented. I don't know why, but this is a patented probe. So the color of the probe matches the color of the brush size head. So if it is a blue, you'll use blue. If it's a red, it's a red. So it's very simple. It's simple for you, it's simple for the patient, and patient can also remember. So you have these different sizes in the normal, I'm talking about when in health, okay? And you can chart this patient. So you don't start by giving all the colors of the rainbow, everything. You start with maximum 1 or 2 in the upper. And as the patient gets trained and sees the changes that there's no bleeding, he or she will definitely ask, okay? And if it is a perio patient, so you have the perio series of probes. And there are different techniques which you have to learn. So actually speaking, as you saw, as he beautifully also explained, that zygomatic is not a 1 day or a 2 day course kind of a thing. You need a lot of training, so same way, there are these different techniques. You have the U technique, the V technique, how to use in each situation, the X technique. Why? To maintain the God-given teeth, okay? So another important thing is when we use our interdental brushes, we test 2-3 times. So this ITOP philosophy says once in, once out, done. The idea is just disrupt the biofilm so that it will not, again it has to take its time, it takes around 12 hours, again it has to mature properly and things like that. So every time if you're breaking it, so it solves. If you do it twice a day, fantastic, but at least if you do it once a day, the interdental brush, it is this. So which size is right? We'll just see this video. This is the click system. It's very simple also to use. So if you think I'm having buttery fingers, and it's very simple. So if it's a yellow, you would definitely use the yellow one. perio series. For your ortho patients. So in the starting you definitely have to use a mirror, but over a period of time you will get the hang of, because it gets programmed over a period of time how to insert it. It's just like a toothbrushing. So you have this different, this is whether it's prime or whether it's perio series, and you can use this also for the implants, perio series, because it's plastic sheeted. Okay, so the interdental brushes are a good choice based on those three pillars. They are acceptable, effective, and also atraumatic if used correctly most of the times. Okay, so it's not just a mindset that which is there. But so you may think that we can just use any other interdental brushes. Well, actually speaking, not all interdental brushes are the same. They will not clean those concave areas properly. So you cannot substitute because they are not color-coded match for the same. Okay, so you have to remember this ability to penetrate, the ability to fill the whole space. That is the right combination of the brush which is supposed to be used. Okay, so not to use any other brushes. Then you come to the flossing. So I mean, you would have heard of this controversy in Netflix also, which had come about. Has it gone for a toss? They had removed it out from the thing that you needed to do flossing, and it's not. But actually nowadays the European Federation of Perio also says that you have to do interdental cleaning, but doesn't really insist on the flossing, but just mentions about interdental cleaning. And a lot of studies have shown that, I mean, you may tell the patient, but at the end of the day, even if you do a survey out here, you will know that how many people really do the flossing. Okay, and if you see all the pictures, even some journals and things like that, this is the wrong way of doing the flossing. It should never be this, kept so far away. So in this concept of ITOP, if you do it the wrong way, if a diligent flosser is there, you will notice this floss clips if he's doing improperly the flossing. Okay, and definitely it's not a great thing to do when in the posterior teeth, where you have this thing in that area you are not going to be cleaning anything. Maybe in the anteriors you can do it. So how you go about it is you make a small loop or a rosary kind of a thing, and in a seesaw motion, keeping both the index finger and the thumb very close to each other. That's how you're going to do this whole process, and you can see that beautifully in this video. That you take sufficient, wind it around. That's what's there in your textbooks, in your atlas, and then you do it. That's the wrong way of doing it. Okay, so when is it we'll recommend this as per the ITOP principles is when an interdental brush does not fit at all, very narrow interdental spaces, some food impaction, single rooted teeth, that is your lower anteriors. And if some people are using it fine without causing any problems, then it's definitely better than not using anything at all. So I don't know how acceptable. It's not acceptable to me. I don't know if you all are acceptable. Is it effective? Definitely not in the posteriors. Atraumatic. I showed you about the floss clefts. So you showed me a person who is doing flossing every day and not having floss clefts. I would also love to see such a person. So next, you must have been wondering why I started talking about interdental brushing first, because the core philosophy is on interdental cleaning when you're talking about ITOM. But other than that, what came first? You would have heard the famous chicken and egg story, right? But even that has been, I think, settled now. They said that because of the protein, which is the hen is the one which came first. So anyways, it shows that if you do the interdental cleaning first, the amount of fluoride which enters and all these, a better way of cleaning, definitely, whether it is floss using interdental brush is much better. That's what the literature has shown, doing these different randomized control trials when they have compared. In fact, now even when the guidelines, they have put an important component where the patient is supposed to do, and especially if you're following the British Society of Periodontology's treatment guidelines, they say that don't take up that candidate for a periodontal surgery if his scores are not coming down. So only if his plaque score and bleeding score is down, so using these techniques, then you please take that patient up for a periodontal surgery. So some people have safety concerns. It's definitely safe. There is nothing, I'm not going to get extra black large triangles unless you're doing a large size. Yeah, if you're using a large size and in an area which is small or something like that. So other than that, studies have shown that there is no problem at all. Okay, and so now numerous advocacy groups and all have been talking about this and telling that interdental cleaning is the, so you can follow this 5 steps where you can explain to the patient, use this different evidence, and the best evidence is you doing it yourself, okay, and emphasize on using the correct techniques and the correct size brushes, and definitely he needs to come for review and get that acceptance of this. And coming to the third method, so you know about the toothbrushing, right? So we know that 70% is taken care of the toothbrush. So for that method, you can use, there are numerous techniques, charters and so many other phones techniques, so many other techniques are available. But we know that all these videos and all is not like a one size fits all, like even when you're having your suit and tailor-made, right? So it has to be long-term adherence is needed, that they do it correctly and diligently. And the area they have to focus on is around the gingival margin in the sulcus area. That's where the area they have to clean, because that's where the biofilm is. Otherwise, you can get this kind of problem. So though the gingiva looks fine, there's a lot of caries here. Of course, this person also you would have to treat for the other risk factors of sugary foods and things like that, snacking and all those things. But not just taking the burr and filling up everything with a beautiful, nice composite and showing the aesthetics, but forgetting to tell the patient how to maintain those beautiful restorations which you would do. So the toothbrush, you have to analyze this, and also the bristles are of importance. So when we tell, especially in this Curopox, they have something called as Curen filaments, which is different from the nylon filaments, which are 4 times more resistant to water, and they are more denser. And a question for you is, when you're using your toothbrush next time, just think about how many filaments are there in the brush. Because if you're having a slightly denser brush, like the 5460 has 5460, whereas a normal toothbrush, which you're using, Colgate or any other, is around 2000 to 3000. Of course, now Colgate has also come up with a new brush called as 7500. So yeah, they are also coming up with new things. And the right way to hold it, right? I mean, all these things we never thought. We just hold a brush anyhow we want to hold. But how do we use a brush? So we use it in the right technique called as the pen grasp, which helps about in beautiful cleaning. So if this is the comparison slide just to show you schematically, if it is dense and if the bristles are not dense, what will happen? It will not clean properly. So that is why you should take care about what type of toothbrush you're also using. Definitely nowadays people don't use hard, but if a person that's the first no for you, that he has to change his or her brush, and the right technique which he has to use, because a hard person may be thinking that, oh, only when I do like that will it get clean. But that's not exactly, because biofilm is not like stuck with super glue. So if you diligently remove it, you can easily remove it. and you need to do these short circular overlapping motions with 2 to 3 teeth, and you have to take care of all these things. All these things sometimes we don't bother, this elbow coming down and things like that. So all these kind of training have to be given on the dental chair itself, the patient using it, the right technique, right way is holding. And this brush has an inbuilt, because it's octagonal head, so if you just do a small turn, you get that exact 45 degree. Again, there is no rocket science compared to a flat-headed brush. Okay, so this is one patient here, which previously, as you can see, that it is a journey. It's not like one day, everything. So this is a kid, slowly over a period of 1 year, you can see that how the plaque deposits slowly are decreasing. And this is the mother here. Especially I want to highlight how just with the toothbrushing you can do it. You can notice just with a simple toothbrushing how clean it has become, and how also interdentally it has become. So they're not like some digitally touched images, but this is the actual picture. And coming more towards the end now, the power toothbrushing, so they have their own called as hydrosonic, because there is a solo technique, so they have the brush head for that, and it has got already a curve built into that but when you're talking through the literature, difference between mechanical, whether a manual or you want to use an electrical, you can use either. Though some studies say that in the initial you might find a good, but it's just like our phone, right? Starting we are using it nice, and after that it falls down and everything, till we get the new phone, we don't bother. So we just see how to use this hydrosonic brush. So this hydrosonic, the water action along with it, when you're, there is a 7-speed process, so especially in the 5th, 6th and 7th is when that hydrosonic work takes care. But if you are in the lower speeds, it will definitely be just like a normal, just electrical brush. No hydrosonic action. See that it's not like just a diagrammatic representation, and it's very good, especially on the lingual surfaces, also when for your orthodontic patients. Yeah. And the most important thing which you need to tell the patient is, okay, you tell your patient this, but you should tell your patient when you're using the brush not to do an extra motion with this with these electrical brushes. That is very important. Sometimes we miss to tell. So how much time do you think that we need to brush? 2 minutes, 3 minutes, 5 minutes? How much time? Well, the ADA says you need to brush 2 minutes per day. So I ask you now, some students and things like that. So how much time do you need to study? Maybe 1 hour a day, 2 hours. Anybody says like that? Nobody says, right? But we are so focused. But that at the same time does not mean whole time you're studying, right? At the same time, it does not mean that you're going to brush for 10 minutes. But each patient is different. So you have to understand that difference. And that's where you being the doctor, you being the person concerned, you're giving a holistic one-to-one approach. And that's what I mentioned about the P4 approach, about how you can get it. And the best simple test. Just lick your teeth like that. If it is smooth, that means you're done. If you're not, just take the brush and go back in again. Okay? So that's a very simple thing, how to know it. So yes, it is acceptable, it is effective, and definitely atraumatic, okay, if you are using it properly. So I'm coming to the last technique, that is the single or the solo brush. Okay, so generally we would give it only in ortho patients to clean around the braces and things like that, but it is a beautiful brush because it really hugs your tooth. That's the thing, and you use these small Parkinson kind of hummingbird kind of motions to clean individually, and it's beautifully shown in the Ratishack book, the only book there which has this technique called as solo technique. Okay, so it takes a lot of time, okay, and is definitely not for all the patients. Okay, so who has a lot of time, and you can just see in this video. So there are two sizes, definitely go for the 006, 1006. 009 is a slightly longer one, so you can get them, especially in starting, to use with the smaller one. But the whole concept of ITOP is that get that toothbrushing out of the bathroom. We are so used to toothbrushing in the bathroom with the paste and things like that. The idea of ITOP is to get it out, just disrupt the plaque and retain your teeth for it. So you can use it to clean Acceptable? Definitely not. Effective? Yes, if done in the correct, and definitely it is non-traumatic because it's each individual tooth which you are treating. So these are the two ones which are available. So you know that the focus always is to clean on the sulcus, but you need to clean all the areas, especially even interdental. Otherwise, you're also going to get proximal care. Your the occlusal surfaces also you need to clean up. So basically, in a nutshell, all the 5 surfaces you need to clean, and they are definitely effective in disrupting the plaque biofilm. And with this, I would like to conclude by saying that we know that when we see gingival inflammation, we may be actually seeing whole body inflammation. They have found the link, and for those who are wondering that we are finding more and more associations, so let's try to eliminate this important risk factor. This ITOP principle aligns well with the S3 guidelines which are published now. The clinical practice guidelines for treating the periodontal diseases, and interdental brushing is definitely on there to use, and it provides all these. And the PFA model, which I was talking about, yes, it is predictive. I showed you the different things. It is a definite preventive approach. It is personalized because one size fits all you cannot give, and it involves the participation of the patient. Okay. And so we have these 4 pillars again of the ITOP, which we use: the interdental cleaning, the loop method of flossing or the rosary method of flossing, the tooth brushing, and the solo technique. Okay. So with that, I would like to say that you should be a light bulb movement. And once Giri Sedilmayer, when he was giving a conference in Mexico in a full room of participants, and he talked about these principles and things, somebody jumped up from the audience and said, "Viva la revolution." And the audience caught on to that, and everybody shouted because it was something different, because everybody talking only about all these advanced things and this thing, and nobody's talking about how we can incorporate these simple things as chairside time things, and they don't require extra great skills. These are simple skills which we as dentists, so we need to help, support, assist and guide our patients. We have the different sizes, whether it's the normal prime series for the normal healthy patients, like in my case you saw, or you have the perio series for our periodontal patients. Nothing to worry if one is a perio brush, there's nothing to harm. The important criteria is there should be no bleeding when you're using an interdental brush. And with that, I want to say thank you for your patient hearing. I hope I could stimulate some minds to understand this process, and so that you all can dig about and find about more about and learn more about it. Thank you.
Thank you, sir, for taking us back to basics with a modern approach. And it was quite interesting, sir. And I'd like to invite Dr. Anmol Bagaria, Dr. Ashish Chandra, and Dr. Uday Kumar to present a token of appreciation to our speaker today. Invite Dr. Anjani Pathak.
Good morning to all of you. So myself, Dr. Anjani Kumar Pathak, the professor in the Department of Periodontology, King George's Medical University, Lucknow. This is the picture of my college. It is around 115 or more years old university, and it is located in this Lucknow, which is called as the city of Nawabs, which is very rich in heritage, culture, and different types of cuisines. So the topic of my presentation today is the implant maintenance. So maintenance of implant, it requires a multidisciplinary approach in which oral radiologists, oral surgeon, prosthodontists and periodontists, they should all come together for planning, better execution and maintenance to ensure best possible outcomes. And the long-term success of implants, it depends upon the effective home care by patients and professional procedures in the dental office. So if we talk about what are the various diseases around implants, so basically we broadly divide into 2 groups. First is the peri-implant mucositis and peri-implantitis. In first picture, we can see there is a tight mucosal seal around implants, no plaque, no bone loss. And in the second picture, there is some plaque around implants and slight amount of inflammation, and there is no bone loss. Though it is called as peri-implant mucositis. And in the second picture, there is a small amount of bone loss is also present. So this is called as a peri-implantitis. So amount of bone loss is measurable. And the etiology of this peri-implantitis or peri-implant disease may be bacterial infection or biomechanical factors. So as we all know that microbial plaque is the main culprit for peri-implant disease. So again, in the peri-implantitis or peri-implant mucositis, the bacterial plaque is the main culprit. And the second factor for peri-implantitis or peri-implant disease is the biomechanical factors. Whenever any deflective contact or whenever any excessive biomechanical forces present on the implants, that will result into the high stress and micro fractures in the coronal bone to implant contact area, which results into the loss of osseointegration around the neck of implants. And these are the various biomechanical factors which are responsible for peri-implantitis. That first factor is the implant is placed in poor quality of bone, and second, implant's position not favor ideal load transmission over the implant surface, and patient has a pattern of heavy occlusal functions associated with the parafunctions, and prosthetic superstructures, that is crowns and all, does not fit the implant precisely. There are certain diagnostic parameters, and these diagnostic parameters which are used to measure the peri-implantitis are similar to which are used to in gingivitis and periodontitis. These are the parameters like plaque assessment, bleeding on probing, peri-implant probing depth, width of keratinized mucosa, suppuration, occlusal evaluation, radiographic evaluation, evaluation of implant stability or mobility, and PISF, that is peri-implant sulcus fluid analysis. This is a criteria given by Mumbai et al. Peri-implant marginal mucosal indices, and it is scored from 0 to 3, from no bleeding to heavy or profuse bleeding. And the bleeding on probing, that's the important thing, is that the bleeding on probing is a negative predictor of the disease, which means if it is absence of negative absence is an indicator of healthy soft tissue around implants. And peri-implant probing depth, there around 3 to 3.5 millimeter of probing depth is considered to be normal around the implant surface. If it is exceeds, that means the peri-implant mucositis or peri-implantitis may be present. Suppuration, if suppuration is present, that means it is a definite indicator of the disease activity, and it indicates the need of anti-infective therapy. Again, there are so many biochemical markers which are various cytokines, interleukins. Their concentration is increased during peri-implantitis, so they can be act as a potential biomarker for peri-implant diseases. That's a very important thing, that is occlusal evaluation, and any signs of occlusal disharmonies like a premature contact or premature interferences should be identified and corrected to prevent the occlusal overload. So we have T scans which we use to evaluate the occlusal contacts. And these are the certain complications. We can see the abutment loosening, which is considered to be one of the most common complications around implants, and which may lead to the peri-implant bone loss, and which may lead up to the implant failure. Now, radiographic evaluation, slight amount of bone loss around 0.2 millimeter per year is considered to be normal around implants. And if it exceeds beyond this, then it is definite indicator of peri-implant disease. Now, implant mobility given by Mish et al. In 2007, which is scored from 0, that is absence of clinical mobility, to 4, and with 4 which is visible, moderate to severe horizontal movement. Now we have perio test in our department. which we use to assess the clinical mobility. Now coming on to the implant maintenance. What is maintenance? So it is defined as a state of being sustained in a desirable condition, and in 1989 the third workshop of the American Academy of Periodontology in 1989, they renamed this term and given a new term called as supportive periodontal therapy, which includes the periodic evaluation of implants, surrounding tissues and oral hygiene, which are vital to long-term success of dental implants. What is the rationale of this supportive periodontal therapy? First, prevention of the disease, which is very important, prevent progression of existing diseases, and prevent recurrence of disease after corrective therapy. Now, maintenance can be broadly divided into at-home implant care and second, professional hygiene care. At-home implant care, the most important thing is brushing. You should use modified pass technique or pass technique, as we are using around natural teeth. So same technique may be used around implants. Interproximal cleansing aids like floss, various dental flosses, interdental cleansing brushes and water flossers. This is another device which is called as Rotadent, and this is a type of powered brush which is a combination of brushing and flossing both, and it removed around 92% of plaque in the first minute of brushing. So this is an important tool which we can use. Now coming on to the professional hygiene care. So first and foremost important is the selection of instruments for implant surgical treatment and non-surgical treatment. The instrument should not be bulky and it should be disposable or able to be sterilized, and it is adaptable to the implant sulcus, and care must be taken not to scratch the implant surface of titanium and other materials, and manufacturer's instructions should be followed. First, these are the periodontal probes. Either they may be used plastic probes or titanium coated probes. This is implant prophy, which is plastic hygiene instruments we can use around implant surface. They do not produce any scratch mark on the implants. This is a plastic coated scalar tips which we can use around the implant surface. They do not produce again any scratch mark on the implant. These are the called as plastic tips, which is used on the instruments, which can be used with these instruments and used around implant surface. The handle may be sterilized and the tips are disposable. These are the titanium scalers which we can use around implant. They should be used with caution that they may produce scratch marks. And these are the tips which we insert on the scalar tip, and they again don't produce any scratch marks. Now polishing. Fine grit prophy paste we can use around implant and crown surfaces. These are the locally applied chemotherapeutics like subgingival irrigation, 0.12% of the subgingival irrigation with chlorhexidine, arrestin microspheres which we place in the gingival sulcus or peri-implant mucosa, which can be used, and controlled release devices like periochip, which is made up of chlorhexidine and tetracycline fibers called as acticide, may be used around implant mucosa. Now coming on to the management of peri-implantitis, we divide the management of peri-implantitis into two groups. First is the conservative therapy and surgical therapy, and we in our department we use this protocol which is called as a CIST protocol, cumulative interceptive supportive therapy, and given by Mumbai in 1997, and it describes the therapy on the basis of probing depth around implants. If probing depth is around 3 millimeter or less and there is no bleeding on probing, so no treatment is required. And if bleeding on probing is present, mechanical debridement is sufficient and it is given as a protocol A. And if pocket depth is 4 to 5 millimeter, so antiseptic cleansing along with the protocol A, that means mechanical debridement, polishing and antiseptic treatment will be sufficient. And then if pocket depth is, if you expect pocket depth more than 5 millimeter, then take a radiograph, and if bleeding on probing is present, but there is a no bone loss in the radiograph, so antiseptic cleansing will be sufficient. But if bone loss is present and that bone loss is less than 2 millimeter, so along with protocol A, B, we should use systemic or local antibiotic therapy. But if pocket depth is more than 2 millimeter, bone loss is more than 2 millimeter, so we should use protocol A plus B plus C along with the resective or regenerative therapy depending upon the type of defect. So conservative therapy includes the removal of plaque deposits with plastic instruments, polishing of all accessible surface with pumice, subgingival irrigation, systemic antimicrobials, and photodynamic therapy. The photodynamic therapy, in this therapy we use a blue photosensitizer. We place that photosensitizer in the periodontal pocket and irradiate with the diode laser for about 1 minute. Now coming on to the surgical technique, we use basically two types of therapy: resective therapy and regenerative therapy, with definite indications. Like resective therapy we use where the moderate to severe horizontal bone loss is present, 1 and 2 wall bone defects are present, and implant placed in an anesthetic area. And regenerative therapy we use implant allowing complete closure with flap and moderate to severe circumferential intrabony defects, and where 2 and 3 wall bone defects are present. And resective therapy basically includes osteectomy, osteoplasty, and implantoplasty. This is one of my clinical case. In the first picture, we can see a very huge defect around implants. We take a round burr and remove all the threads. That is called as a implantoplasty. And you can see the surface now becomes smooth after post-implantoplasty. Again, in the first picture, there is a huge defect around implants. So we debride the defect, removed all granulation tissue, placed a bone graft, and in third picture, we placed a barrier membrane, and you can see the difference of bone fill in radiograph, second radiograph, pre-operative radiograph and post-operative. So again, in this radiograph, there is a bone loss present in the around implants. We debrided the defect, placed bone graft, a membrane is placed. So in the first radiograph, we can see a bone loss. So we debrided the defect, removed all granulation tissues, placed bone graft and membrane, and then you can see the bone fill in the second radiograph. This is another case with bone loss around implants, and in the second bone fill. Again, in the first radiograph, we can see that defect in second radiograph photograph. We debrided the defect and placed a barrier membrane, and after 3 months we re-enter in the area, and you can see a good amount of bone fill is present. So there is a criteria given by Albrechtsen in 1986. What is the success of implants? So he gave 4 criteria: that individual unattached implant that is immobile when tested clinically and radiographically, that does not demonstrate any evidence of peri-implant radiolucency; bone loss that is less than 0.2 millimeter annually after the implant's first year of service, and no persistent pain, no discomfort or infection. And by these criteria, around 85% of success rate at the end of 5-year observation period and 80% at the end of 10-year period of minimum level of success. So to conclude, implants are more susceptible to inflammation and bone loss compared to the natural tooth. And one of the key factors for the long-term success of oral implant is the maintenance of healthy tissues around them. and a tight recall schedule and a comprehensive maintenance protocol needs to be followed to ensure long-term success. Thank you.
Well, in order to felicitate our speaker today, let me invite Dr. Anmol Bagaria and Dr. Ashish Chandra and also Dr. Gutmann. Invite Dr. Cohen.
Good morning, doctor. How are you? And welcome to Sri Lanka. And I would first I would like to thank the organizing committee of this event, and a special thank Dr. Uday Kumar and my teacher, Dr. Jebin George and Dr. Sudigaran and the Johnson sir. I learned a lot from them. And this is my today topic, and we move on to the okay. When you see this video and photos, you can realize the importance of the front teeth. Okay, missing of front teeth lead to a significant role on the patient's aesthetic, and it compromises speech, and it the patient hesitate to smile, eat in the public. So there's a lot of various methods to replace the front teeth especially in the aesthetic zone. So today I am little bit talk about the immediate placement and temporization in the aesthetic zone. Okay. I am using this magic because the immediate placement of and temporization, it has a very big challenge, because mostly the bone quality and quantity. Because the bone, we need to get the very good primary stability to give the provisional or temporization. So we want to, as a clinician, we want to do some magic for the immediate loading and temporization. Okay, we move on to the case one. The challenge is that she had the accident 20 years ago, and is around 2 or 3 years she feels there's a past discharge and mobility of the tooth, and she is living in UK, and she came for the daughter wedding here, and she need the immediate replacement for her daughter wedding. See the challenges. When you see the CBCT OPG section, and you can see the bone loss up to the root on the distal side. And when you see the 3D CBCT and completely loss of buccal plate and the distal bone, and completely mobile grade through mobility. And there's a periapical infection on one also. Yeah, what is our plan? And can you see that? The defect site. What is our hope to give the immediate placement? And my hope is I will start drilling the rest. I am hoping this amount of bone is around 20 millimeter bone is there and above the root level. So I will start drilling from here and go and engage in the nasal flow. Okay, this is my plan. Can you see how we execute the plan? And immediate temporization using as our crown and bridge technique. So with a normal chair side technique, we treat this case. and take the alternate impression and keep it in the side. And after that, I take my periodont. This is my favorite tool, and nicely detach from the adjacent tooth without damaging the soft tissue as well as the hard tissue. I take it out, nicely curettage, and take my first drill, damp drill, and drill it up to drop. And check it with my probe around the implant contact, and after that I take my active thread implant and insert it. I took the initial torque of 110, more than 110, and you can see the torque rate is maximum is 80. I reach more than 80. So it is enough for me to give the primary stability. I got the enough primary stability. And second step, I want to give the provisional. So I take my 30-degree stock apartment. It's basically it's a chair side. Everything we are doing in the chair side. I take my 30-degree angle apartment. This is the problem we are facing because we want to take it out the bulge part because the temporary provisional need the soft tissue growing inside without any tension. Okay? What I did it, I removed the bulge and make a groove and insert in the patient mouth and cut temporary crowded with material, inject it and readapt it as a crowded bridge temporary and remove it. And remove the temporary and clean it well and graft it with zero graft with membrane. This is what I'm calling as ice cream cone technique. And replace with the temporary provision. And rest of the part I cut it and polish it and send it to the patient. Okay, this is the photo after 2 days. Sorry. After 2 days, but she came to remove this black mark because I marked the pencil to make a subgingival. So I take a surgical swab and clean it. So this is yeah. This is the first case I did it in the resorb bone anterior zone. Okay, and this is the IOPA with the prosthesis, and this is a CBCT, and you can see my implant go and engage in the is around 2.5 millimeter nasal cortical bone and got the primary stability. And see the view after engaging in the nasal flow. This quick dent implant, it has the smooth apical part. It go and in the nasal cavity. It does not go give any irritation to the soft tissue. And I have the 20 millimeter very good bone to engage my implant and give the provisional. Okay, this is a second case I would like to discuss because she extracted tooth 1-3 and she had the defect on the hard tissue on the depression. She is worrying a lot on that also. Very high smile patient, and I use the technique called palatal rolling technique. I take my aorta and remove the keratinized tissue and took the full thickness flap from the palate, from the palate area to lift it up and place the implant and place the healing cap and send it to the patient. And after 3 days, I call the patient and send it to the lab. What I'm going to tell about this is the crown I received from the lab. Is it an ideal crown to sit it in my patient? So our duty to do some alteration. See what are the alteration we want to do. Global composite and fill the defect or the concave area and make a nice contour temporary. And cut it and polish it. I make the supragingival margin and the cervical margin also concave. It gives very good soft tissue adaptation. And can you see that? Sorry. Okay. And can you see the difference between the crown, temporary crown received from the lab, what we did it in our chair side. So it is mandatory to give the soft tissue, especially immediate placement cases, temporization cases. Okay. And after 3 months, I call the patient and remove the provisional and remove the metal ceramic crown also, and I did the scan. I did the scan. Can you see the? Sorry. Can you see the soft tissue defect is corrected nicely after 3 months also. There is no recession or defect. And this is a digital printed zirconia crown and the casted or cement retaining implant crown. And this is the before. Can you see the defect is corrected, and this is the final prosthesis. Okay, this is a very good case because he is a Chinese patient. He is working as an engineer in the port project in Colombo. Okay, he met an accident with the metal pipe, and he came, and I asked to bring the CBCT. This is the slide, the fractured tooth area. Okay, when you using the conventional type of implant, well, I am also using, but I can maximum place 11.5 or 13 millimeter implant for this case. Is it not enough for my view to give the provisional or temporization? So my idea, my decision, I drill it from, go and engage in the nasal flow at the nasal spine area to get the very good primary stability. So, and for this case, I use the technique using the template. You can see the template also. I use my period top. I nicely inserted it distally and mesially, and without damaging the palatal plate, I remove the tooth. And this is my root extractor. I bought it from India. It's a Julandas design. Okay, I take it out nicely, and my aim to engage in the second cortex, and take my last drill, single drill. I drill up to drop the nasal flow and inserted my only one drill. I inserted into my place which I want to engage. This is the movement called corticalization of the cancellous bone. Move forward and little bring backward, little one thread and moving forward, because it contains the, like a densite, contains the cancellous bone. Okay, final tightening with the implant driver. And one more thing, if you are using the hex implant, internal hex implant, you should keep the flat surface on the buccal for the orientation and everything for the prosthetic part also. Okay? Sorry. And this is my tie base. Take it and fix it, because I am always keeping the flat surface on the buccal, because it's easy to give the temporary. And check it with occlusion and remove it and fix the lap analog and insert it into the, this is a template for the anterior tooth. Okay, this is a triangular, is it visible? It's a triangular shape, and using my flowable composite, I get the triangular shape for my soft tissue adder for the soft tissue profile. Okay, and get the triangular shape and remove it, and rest of the part build with the flowable composite. After that, I nicely polish it, cut it, and make a supragingival margin and concave on the cervical region and fix it in the patient mouth. And rest of the part, the usual composite build up. Polish it. And this is the profile after 3 months, because it's not 3 months, it's around 2.5, more than little bit more, because he is leaving from Sri Lanka to China. So this is the profile. Can you see the soft tissue adaptation around the implant? And can you see the hex? It should face the buccal side. It's easy to angle abutment. Is lab also very easy to insert it and to fabricate the final prosthesis. Okay. This is after 2.5 months. I place the cement retain crown and see the, is there any bone loss? Go and engage what I decided. Okay, this is a view and this is a final prosthesis in the patient mouth. Okay, these are the single case we are using, because we are to get the primary stability, we are using some technique. Usually I am using the single drill or 1 or 2 drill to engage my implant. And second drill up to drop, because I learned the word from the Johnson sir. Drill up to drop means we go and perforate the second cortical bone. And second thing is this active thread implant you should use it. And long implant, and you can engage 2 or more cortex. Sometimes we are getting the stability from the antral wall also, and long implants give the good implant, bone implant contact, BIC. And tilt implant, when you tilt implant 10 degree, you can go more 1 millimeter more implant you can place it. And immediate splinting and rigid process is very important. Prosthesis not move. And rigid splinting and cross-arch stabilization for a full mouth cases. And this is my favorite implant I am using. It has the smooth surface in the apex and the smooth surface on the cervical area. And if it is exposed to the soft tissue, it does not give any problem. These are the acute taper or sharp apex and super aggressive self-cutting thread and compressive thread on the cervical area to compress the bone and depth groove for the sharpener effect. And I need grade 5 titanium. I am giving more force because the grade 4 titanium, I use some implant. It has a flowering effect. It lose their prosthetic internal hex and long length for the good BIC. And this is the case. We moving to the multi-tooth, and she is having the grade 3 mobility on the 3132 and 4142. Immediately remove it. Take a normal alternate impression and remove the tool and place the implant and fix the tie base. Check the occlusion and fitting. And take it out and remove the excess and cut and polish it. I received from the patient mouth. I inject the flowable composite, nicely cut and polish the supragingival margin, concave, and it should be a screw retain. And check the adjacent tooth clearance and everything. And we move on to the segmental immediate loading. The patient, he also from Italy, and he is complaining about the second quadrant to replace it. And see the CBCT view and totally grade 3 mobility on the second quadrant. So my plan is take it out in my active implant, I drill it up to drop and check the bone condex with my probe. And the angle corrected with the multi-unit. And immediately scan, this is the multi-unit scan, send it to the lab. Lab they make the, and can you see the engagement? Lab make the metal rigid with PMMA, polymerase activation. And see the path of engagement in the patient mouth. All 4 implant is engaged nicely, and with the bar, with the PMA, immediate temporization. And finally, we go for the upper arch full case, and this is a patient. He is the priest means what do you call it? He's doing the puja and puja. Okay, and the pronunciation, everything is difficult. He is from Canada, and he is wearing the RPD normal, remote partial denture, and asked to bring the CBCT, and this is a view we planning to. There's a Johnson said, I would like to keep one tooth at least in the patient mouth for my benefit, because I want to take OVD and everything is easily, if the one tooth is present, it maintain everything, it give the good but he also liked, but he liked to go for the whole extraction and go for the full, because I planned to go for the later, and you can see after the final X-ray, and I planned to extract all the things, and he is wearing the removal pass attention, and this is and remove it and drill it. Accidentally my drill is break inside my plan. You can see how I bypass and place the implant. And place 6 implant and place the tie cylinders and drill his extending denture and place it in. Place it. Send it to the patient. After 5 or 6 days, I called the patient and I did the scan. And this is a multi-unit scan body. The benefit of one tooth is remaining in the patient mouth. Can see the bite record. It's very easy to me. And immediately I sent to the lab. They design it and send me the soft copy. I print that in my clinic and check it and get the consent from the patient. Lip line, the size of the tooth, OVD, and bite everything. If it is any defect, I rescan I cut it and polish it, everything, I rescan it and send it to the lab. They exocad, they join together and make a, this is the PMF, and this is the problem I did it because I broke in my long drill because I am little inserting always more forces. Okay, I bypass it. I go and adjacent to the antrum bolt and engage in the canine buttress area. Okay, and you can see I place the one implant here. Later I remove it and connect to the next level. And this is a one implants go and engage in the palatal cortex, and this is the final outcome. And the conclusion is because nowadays the patient demand is more immediate loading, immediate, everything is immediate. Okay, so our duty to learn and give the best option to the patient. And your selection of implant system also should have all the prosthetic option, and it should have the active implant system with you because to treat this patient. And thank you so much the organizing committee and again Dr. Uday Kumar. He gave a lot of chances to me delivering the speech. And I thank the Indian Dental Association also. They gave the chance to give the as a guest speaker in the 75th ICOA conference last month. in Chennai. Thank you so much.
Thank you, sir. Thank you, sir, for that inspiring lecture, allowing us to bring instant smiles on our patients. And to felicitate our speaker, let me invite Dr. Anmol Bagaria, Dr. Ashish Chandra, and Dr. Uday Kumar. To speak about microvision, macro impact, the significance of magnification in endodontics. Over to you.
The last line. Hello. Good morning. I can understand this cold response. Instead of sitting in a beautiful city, with beautiful seashores and beaches, we are engaging from the morning in a scientific session. It's just a punishment for your mind. I think if I given a chance, I sit down a rock and just beneath the sea, and for the heat you can have some beer also. So, how many of you using microscope in your practice? Anyone? Please don't ask me any question. I am very new in the microscope field. I'll just share some idea about my journey towards the microscope. And it's just electronic hiccup. So myself, Dr. Vijay Kumar Shakya, a professor of endodontics at the King George's Medical University at Lucknow. The institute which has having a history of more than 100 years in the field of medicine and dentistry. And this is my presentation, micro vision and macro impact. This title of this is copied from ChatGPT because I am not good enough in English. So I want to make a very fascinating title of my presentation. That's why I asked ChatGPT to do something for me, and it works excellently. My teacher and mentor, Professor Anil Chandra, who teach me how to deal the situations not only in endodontics, in every field of life. Sometimes we stuck in a case, doesn't find out the canal and ask the sir, please help me, I am too much tired because for last 2 hours we can't having a single canal in this tooth instead of waiting till 13 or 14 patient outside. Then he gave very simple tip that just fill the cavity with cavity and send the patient. Tell him or have to come tomorrow and having a coffee outside in the canteen, you will definitely find out the canal next day. And it works always. So this is the person who teach us how to deal the problems in our life. This is my disclaimer, I am still learning. And second and most important disclaimer that this presentation is the smallest presentation of this scientific meeting. It doesn't having any video. It has a few small case presentation, I think 2 or 3. Because this field doesn't having any set criteria for that you need to know before going for the microscope and doing some good work. It's only a tool, and you can only make yourself very familiar with it with working with the microscope. This is the only way. So these are the 2 passions of my life: music and magnification. I'm sorry, video is not. Okay, so with these 2. These 2 girlfriends is my life. I am successfully running my married life from last 20 years. Magnification and music. So especially designed instrument like dental operating microscope. Earlier it is designed only for ophthalmologists and ENT surgeons. Dentistry, it is coming late in the picture. Micro dentistry. Our company make ergonomic instruments to do the dental treatment also with the help of microscope, and definitely better ergonomics, less fatigue to the eye, because it is always eye is looking parallel on the eyepiece, so if there is
very minimum fatigue to the eye. Whenever you do routinely treatment with the help of loupes or naked eyes, you feel after some few patients need some rest, but with the microscope I can do the patient hours and hours. And free of shadow. Everything is clear. You can treat the patient, negotiate the canals, retrofilling, restorative dentistry, etc., and all. Above all, the retrieval of broken instrument, which is very fascinating and fashionable chapter of this microscopic endodontics nowadays. So these are the components you all know: eyepiece, the objective lens, magnification changer, body, and have some sort of 0.04, 0.06, 1 magnification factors. All these, this I think. Yeah. Sorry, I am not on this pointer. So these are the limitations of human eye. You can see are very few X magnification of eyes rather than working on a loop and on a microscope. So these are the low, moderate and high magnification settings, and these are not the guidelines. Because doing their microscope training and train themselves and set some guidelines, but it's not a universal one. But you can low magnification, always start with the low magnification because it is very easy to focus. Because it's a learning curve. You can't do every patient on indirect vision with a good magnification tool like rhodium coated mirror and so much smaller size instrument. But sometimes we need higher magnification also, especially in the file retrieval cases. So position of operator in my undergraduate case time, I am suffering a lot from the cervical spondylitis and visited to the orthopedic OPD, and that time Dr. Jain is the HOD of orthopedic, and he told me that तुम्हारा धंधा ही ऐसा है कि तुम्हें हमेशा बीमारी रहेगी. It's in Hindi that your profession is like you have always suffered with the spondylitis. Do the exercise, it never cures, and do your work and try to live with this problem. But the microscopic training, position of patient is another thing. Microscopic training make me sitting straight. It's amazing when you are having any neck problem, because these are the common pictures when we are a student, or sometimes we also used to take work, especially in endodontics, when we did not find the canals and try to view directly on the posterior tooth. The straight line access is very difficult task with bent neck. You can see these pictures, every picture, my posture is very straight. This is very less fatigue producing posture when we are doing patient on the microscope. So this is the beginning of my microscopic journey. I make a loop with the help of a needle and wire purchased from Amazon. It is very thin, 0.08 mm molybdenum wire, which is used by these cell phone repairs to remove the screen and successfully remove the loose wire from the canal. It gives me a lot of confidence in me. So the main armamentarium as per endodontics is rhodium coated mirror, rubber dam, no treatment, nothing. Especially in endodontics, it's very difficult to do a case without rubber dam magnification and ultrasonic. In UZ period, ultrasonic means this is the tool for periodontist. But nowadays, without ultrasonics, it's very difficult to perform a good endodontic access or debridement. And some special tools like loop devices. This loop device is made by Yoshi Tarashi, a famous endodontist, you might have heard, from Japan. In their kit, having some ultrasonic tip also. So this is a case presentation, a 13-year-old boy. You can see the X-ray, how nicely he obtured his own teeth with so many metal pieces, because he worked with his uncle in this bike repair shop. So he used to fill this canal with so many objects, and it is referred from Department of Periodontics to me. And with this instrument retrieval kit, I am successfully remove all these and observed this patient. He is very happy. His parents are again very happy. And this is another case in a little boy. He inserts some foreign object. His mother told that इसने कुछ so many things he inserted, but in the X-ray it doesn't show anything. I asked radiology department for help. They also did a 64 CT slice, CT scan, and does not make out anything which is visible on radiographically. But in the microscope, I realized there is so many pieces of pencil and nail is there, and then we will perform a regenerative endodontic therapy to that particular patient, and it's very amazing. You can appreciate the formation of root, and after that, this means that I am able to remove all these pieces of pencil, and otherwise their recurrence of infection may happen. This is another case of broken file. It is easily removed with this 4-5 mm long piece of file from a calcified canal with the help of this loop device. The two important things when we performing the endodontic, especially this type of complicated cases, one is ultrasonic. You should have good ultrasonic tips. Flexible is more better, and this loop device. These two tools is amazing for removing this type of cases. This system doesn't enable this video that I want to show you. This is another referred case. The patient told that the doctor is able to find only one canal, and in that particular one canal he broke 4 different pieces of file. It is good for patient that here he is not able to find out another canal, then maybe there is 4 or 5 pieces of file in another canal also, and it is easily retrieved with this ultrasonic device, and you can appreciate the good observation of this patient. This is another patient with apexification technique. The calcified canal, a big task for an endodontist to find out. With the magnification, you can find out the small white area in the whole calcified. These area made by the dying odontoblast, which doesn't fully calcify. When we start you can see the different calcified cases. The odontoblast cells start calcifying and confine themselves toward the center. And at the center, the last few odontoblasts, they doesn't having enough supply, energy supply to calcify themselves, and they die. So it can only be found out with this magnification device. By naked eye, it is very difficult. You can assume that this canal can be negotiated. So this is another case. This case of file retrieval with the help of microscope. And this is a straightening case. You can see in the X-ray there is a radiopaque body inside the tooth of the patient. When my PG tried to retrieve it, it pushed towards the periapical area. And patient referred from the ENT department for a lesion in her nose. It's a sinus opening, and constantly it is, after giving so many settings of different antibiotics, it doesn't resolve. Then I see under the microscope from the nasal side, I realize some metallic objects are there, and it is removed, and patient is happy and doesn't return for the rest of treatment because her problem is resolved. Pus formation is completely resolved, then she refused to come back and for the further observation. So this is my conclusion with the most 20-year endodontic concern, because in our UZ time, endodontic means doing root canal treatment, doing gold restoration, direct or indirect, and silver restoration. We did not think beyond this, but now the paradigm shift towards the aesthetic dentistry, towards the magnification, and doing good endo with the help of ultrasonics and so many irrigation newer devices. We have good quality of apex locating devices. So now we can say this treatment and the modality of treatment can be predictable, because earlier in common man we can say this is a blind treatment and we cannot trust it. So thank you so much for attentive listening. As I disclose that this is the smallest presentation from my side, a few cases of, because the setting of microscope and all these things take, I think this is a day-long task to tell something about the microscopic endodontics. I just want to see something about the microscopic view so that you can amplify this practice in your routine dental practice. Thank you so much. I am thankful to Cynodent and Dr. Anmol and the team and PFA for inviting me in this beautiful city for this boring scientific lecture. Thank you so much.
Thank you, sir, for that amazing lecture. And to felicitate our speaker, let me invite Dr. Anmol Bagaria, Dr. Ashish Chandra, and Dr.
Excuse me.
Good afternoon to all of you. I'm Dr. Venali, the master of the ceremony today, and I'm pleased to welcome you all to the inauguration ceremony of the 16th World Dental Sciences and Oral Health Conference and PFA Forchard Academic Convocation and Award Ceremony in this beautiful city of Colombo in Sri Lanka. We would like to extend a warm welcome to our chief guest today, Dr. Uday Kumar, Dr. Anmol Bagaria, founder and CEO of Cynodent and PFA Section Chair, Section at Large, PFA Asia Region Countries, Dr. Ashish Chandra, Co-Director of Cynodent and PFA Co-Chair Section at Large, PFA Asia Region Countries. So I request all the dignitaries to grace the dais. I kindly request Dr. Anmol and Dr. Ashish to felicitate our guest of eminence, Dr. B.M. Uwais, International Environmental Founder, TBC, and CEO, Nature and Culture Protect Sri Lanka International, Executive Governor, and Executive Member of Cynodent and PFA from Sri Lanka, Dr. Uday Kumar. Executive Member of Cynodent and PFA from Sri Lanka, Dr. M. Uday Kumar, to share his thoughts with the gathering. Over to you, Dr.
Good afternoon, everyone. The Director of Cynodent and PFA, Dr. Anmol, and Dr. Ashish, Co-Director, and the today's chief guest, Dr. Uwais, and all the delegates from Sri Lanka and our friend country, India, and people who are waiting for their fellowship. Welcome to our beautiful country. First of all, I would like to thank our organizing committee for inviting me to organize this program, because dentistry is advancing globally. It's a digitalized world, dentistry going beyond the medical sector. So it is a great opportunity to enhance our knowledge and the skill by attending this type of program. So I would like to thank again all the audience. Without taking much time, and thank you very much for attending this program and welcome to this beautiful country, Sri Lanka. Have a nice day.
And next, we would like to invite our Chief of Eminence, Dr. B.M. Wise, International Environment Founder, TBC, and CEO, Nature and Culture Protect Sri Lanka, International Executive Governor, to address the gathering.
Good afternoon all. I am Vice TBC International Environment Founder and CEO. Welcome to 6th World Dental Science and Oral Health Conference, PFA Convocation and Award Ceremony. Welcome to Sri Lanka. I would thank you, Dr. Anmol Bagaria, for inviting me. Thank you.
Thank you, sir. And next, we would like to invite Dr. Ashish Chandra to give some insights about PFA. Over to you, sir.
A very good afternoon, everyone. Myself, Dr. Ashish, Section Co-Chair of Pavitra Academy Section at Large Asia region. Now I will give you few insights about the Pavitra Academy. The Pavitra Academy is an honorary dental service organization established in 1936 by Dr. Elmer S. Best, a US dentist. PFA was founded to help dental professionals to prevent its literature from commercial interest. Elmer, passionate concern for knowledge and raising of professional standards, laid the groundwork of the academy. The PFA has 11 global regions, 142 sections worldwide, 55 sections in the USA, 85 sections in the America, Europe, Asia, Africa, and Australia. We have the global members of more than 11,000 fellows. PFA is an affiliate member of FDI and APTF. The academy is named after the Pavitra Rastogi of France, who is the father of modern dentistry. He wrote a book named called New Chirurgian Dentistry, OU Treats des Dents, the first true textbook of dentistry. The mission as a fellow of the Pavitra Academy is to recognize and develop outstanding leadership in our profession internationally. The objectives of the Academy are to fulfill through the meetings of its international section, annual awards, presentation of the Fortune Gold Medal, the Dental Trade Industry Award, and the Elmer S. Best Memorial Award, the Student Merit Awards, the College Awards, and various other awards which you will see later. And also we have the publications which is done in the Dental Abstract, which is a PubMed Index journal of the dental world. The goals of the PFA is to make PFA known throughout the dental world, to have the most outstanding fellow dentists in every country of the world, to select and induct individuals of the highest ethical, moral, and professional standards, to develop service-oriented projects, to orient all PFA leaders with uniform workable guidelines, to make PFA a peer-recognized body by virtue of its appreciation awards, fellowship, and its service to dentistry. This is the PFA organogram. This is the PFA office bearers and the trustee. Dr. Cheryl Billingsley, International President, PFA International USA. Dr. Pankaj Patel, Immediate Past President, PFA USA. Mr. Robert Katoi, Executive Director of the PFA USA. Dr. Anmol Bagaria, Madam, Section Chair, Section at Large Asia region. The PFA Fellowship. The PFA Fellowship is by invitation nomination to honor accomplishment in dentistry and encourage future fellows to the productivity of the dentistry. Professional leaders select fellows based on contributions to dental literature, service to the professions, and service to the general community, thereby bringing credit to dentistry, are almost the criteria sought in recruiting new members. This is the PFA Museum. The Pavitra Museum of the Dental History was established in 2000. The museum houses several displays related to dentistry. The museum is located in Nevada, US. Now these are the camps which are done through our sections internationally and nationally in India as well as in many other countries. Under the PFA sections, various colleges across the Asia region have undertaken a remarkable community service initiatives, demonstrating their commitments to improve public health and well-being. In 2024 and 2025. A total of 1,213 health camps were organized, providing essential medical and dental care to undeserved population. These camps set up in diverse locations catered to the needs of 128,916 patients who were offered the treatments as well as the oral cancer screening, preventive cares and healthcare educations were given to them. This initiative highlights the collective effort of participating colleges to bridge healthcare gaps and foster community health development on a large scale, showcasing their dedication to improving lives through preventive and curative health services. Our future plans of Section at Large Asia region to have the highest number of the fellows, as we already have the highest number of fellows being inducted in a year, that is 350 fellows we have inducted internationally in a year through our Section at Large Asia region. To continue PFA Social and Community Service Awards, to continue various college and student awards for the motivation and betterment of dentistry. Thank you. This is the message from Mr. Ricardo R. Gutmann, who could not make it over to Sri Lanka, but he has a message for you all. I'm just playing it.
Gentlemen, esteemed members of the PFA Academy, to all my fellow dental professionals and distinguished guests, to Dr. Anmol Bagaria, Section Chairman, Sri Lanka, PFA Asia at Large Region, and to Dr. Ashish Chandra, Section Co-Chairman, PFA Asia at Large Region, to all the delegates of the 16th World Dental Sciences and Oral Health Conference, and I thank you for inviting me during this PFA Convocation and Award ceremony. I stand before you today with immense gratitude and a deep sense of responsibility as your newly elected trustee for Region 9 Asia. I am honored by your trust and support, and I give and pledge to serve our esteemed Academy with unwavering dedication. As we gather in this moment, I am reminded of the profound impact that we can make together. The dental profession is not merely a career, it is a calling. A commitment to excellence, integrity, and service to our communities. Our mission at the PFA Academy is to elevate our profession, and it is with this mission in mind that I outline my vision for our region. First is the commitment to excellence. First and foremost, we must foster culture of excellence. I envision a Region 9 that prioritizes continuous education and professional development. We will organize workshops, seminars, and symposiums featuring leading experts who will share their knowledge and insights. By investing in our skills and expanding our understanding, we can ensure that our practices reflect the higher standards of care. Number 2 is transcending the dental profession. Next, we must transcend the traditional boundaries of our profession in dentistry. Since this is evolving, we must be. I propose the creation of interdisciplinary collaborations that will bridge the gap between dental and allied health fields by working together with other healthcare professionals, that we can enhance patient care, promote holistic health, and strengthen our role within the border of healthcare community. Embracing better values and norms in our pursuit of excellence, we must also embrace better values and norms. Integrity, compassion, and ethical practice should be the cornerstone of our profession. I will champion initiatives that promote ethical standards and encourage members to reflect on the impact of our work on the lives we touch. Together, we will build a community that not only upholds these values, but actively lives them out in our practices. Engaging our members. Lastly, I recognize that our strength lies in a collective voice. I commit to engaging each of you in this journey, regular communication, feedback, and collaboration. It will be an essential, where I will create platforms for dialogue and idea sharing, ensuring that every member feels heard and valued. Your insights will guide our initiatives and help us adapt to the unique challenges and opportunities we face in Asia. In closing, let us embrace this opportunity to lead our profession to new heights, as together we can navigate the complexities of our field, inspire one another, and make a lasting impact on the dental community and beyond. I am excited to embark on this journey with all of you, and I look forward to working hand in hand to cultivate excellence in our practices and uphold our values and create a brighter future for dentistry in Region 9. Thank you for your trust, passion, and your commitment to excellence. Let us begin this journey together.
Now, we will start with the induction ceremony.
Now it's time for fellowship convocation and induction. Dr. Bernice Thomas, Dr. Karuna Ramnani,
Okay. Right, thank you, sir.
Dr. Said Asif Hussain,
Did you click it? Right, thank you, sir.
Dr. Karuna Ramnani,
Thank you.
Dr. Thankam Susan, Dr. Mayank Aravind Malik,
Right, thank you.
Dr. Kashmiri Chowdhury,
Excuse me, sir. Right, thank you, sir.
Dr. Amar Haideri,
Right, okay.
Dr. Shrestha Muskan,
Thank you, sir.
Gautam, Dr. Sai Chintamani Anavalikar,
Okay.
Dr. Kasaraneni
Excuse me, sir.
Srikanth,
Sir, look here.
Dr. Sarita Bandari,
Right, thank you, sir. No, please.
Dr. Sarita Bandari,
Okay.
Dr. Das, Dr. Atul Anand Bajoria, Dr. Atul Anand Bajoria, Dr. Abhishek Kumar Gupta, Dr. Abhishek Kumar Gupta, Abdullah. Dr. Manasi Suravade. Dr. V. Elangovan.
Right, thank you, sir. Right, thank you.
Uday Kumar.
Okay, sir, close.
Dr. Anuradha Bahusabe Saheb Patil.
Okay, here, look. Sir, keep it close. Okay.
Dr. Jibin Daniel. Dr. Mehantan Khatira Sahapillai.
Sir, excuse me, sir. Hey, thank you, sir.
Dr. Sirimevan Samarakon.
Yeah, look here, sir. Okay. Right, sir. Okay, sir. Okay. Sir. Okay. Sir, look here. Thank you. Okay, sir. Okay.
Dr. Nazar Abdul Wadud.
Okay, look here.
Next, I'll be reading out the names who will be receiving fellowship but who are not here present today physically. Dr. Ayushi Chauhan Agarwal, Dr. Aditi Kranti P. Biradar, Dr. Maul Sri Bhatt, Dr. Nagaraj M, Dr. Pooja Mahen, Dr. Kazi Mukhalat, Dr. Ritvik Vinay AP, Dr. Rumana Ali Abbas, Dr. Saumya Parashar, Dr. Shalu Jain, Dr. Shabangi Mittal, Dr. Shweta Nar, Dr. Simran Saki, Dr. Soja Mary Vagise, Dr. Uday Kumar Al, Dr. Vaibhav Gupta, Dr. Vivian Flourish de Costa, Dr. Prashant Prakash Jaju, Dr. Jibin Joy Daniel. And we would like to invite Dr. Ashish for the oath. So I invite all the ones who are here today to receive the fellowship for the oath.
All fellows kindly stand for the oath. Recognizing that PFA Academy seeks to exemplify and support the highest tradition of dental professionals around the world, I hereby accept as a condition of fellow its principle and objective. Repeat the oath after me, and at the completion, please indicate your acceptance of the pledge by saying I do. I, raise your hand. I pledge myself as a fellow of PFA Academy to uphold to the best of my ability to honor and dignity of the dental profession and of the academy. I pledge that I will conform my professional and personal practice to the high moral and ethical standards which the Academy exemplifies. To succeed in this high calling, I pledge to devote my best efforts to the continuation of the development of knowledge and skills for myself and others in the state of art and science of dentistry. Everyone say I do. Congratulations everyone. You are formally inducted as a step of the prestigious Tri-President. Congratulations.
Thank you, sir. Congratulations once again to all the fellows. And next, I'd like to congratulate all the awardees for being selected for the most prestigious award. So before announcing the names, I request all the college awardees to share a few insights about their academic journey, community service, and also the scientific research after receiving their award.
Okay, sir. Yes, sir. Look here, sir. Right, thank you.
Colleagues, I'm Dr. Anmol. I'm a periodontist and I'm a Dean of Sri Venkateshwara Dental College, Chennai. I do a lot of lectures on implants and periodontics, but my special interest is also on dental photography documentation. So for the past 2 years, I think more than 60 CD programs I have done for various dental colleges, IDA forums and other things. Almost have 60 plus publications and 20 years of service in the teaching faculty. So I have applied for this outstanding dental educator award and I'm happy. And I thank the Perry Fortune Academy for selecting me as one of the outstanding dental educator award. Thank you, Dr. Ashish and Dr. Anmol, for the opportunity.
Dental Educator Award goes to Dr. Nilima Thozer.
Okay, also going to
Excuse me, sir. Right, thank you.
Good afternoon, all of you. I am Dr. Nilima Thozer. I am Professor and Head in the Department of Pediatric Dentistry at Sharad Pawar Dental College, Wardha, Maharashtra. I am very much honored today to get this Outstanding Dental Educator Award. And related to my biodata, I can tell you that I have 217 publications. I have got 1 patent granted, 2 are published. I have 17 copyrights to credit. Then I have guided 32 postgraduate students. I am a PhD supervisor of 8 PhD scholars, out of which 2 have been awarded with PhD degree. Today it feels with great pleasure to get such an honor from PRA Fortune Academy in this forum, and it is far away from India, that is at Sri Lanka, and I really feel privileged to get this award. Thank you, sir. Thank you, ma'am. And thank you, the entire team. Thank you so much.
Outstanding Dental Educator Award goes to Dr. Ritesh Rambaros Kalaskar. Outstanding Dental Educator Award goes to Dr. Sham S. Bath.
Like, sir? Okay. Thank you, sir.
Good afternoon, everyone. And I am Dr. Shyam Expert, Dean Faculty of Dentistry, ANFA Dental College, ANFA University. I am really happy to be here to receive this award. To say educator, you need one is to educate the people or maybe to convey what you want to convey to your students. And here I want to, as a periodontist, I completely take this opportunity to special care dentistry where we really need upgrading the orange to help the children with the special care needs. Our institution supports all our education systems, especially the research as well as publications. With this, I thank my support system of ANFA Dental College and exclusive all the department who supported this for this awards. Thank you, PFA.
Next community service goes to Dr. Georgie P. Zakaria.
Good afternoon, I am Dr. Georgie P. Zakaria. I am a maxillofacial surgeon by profession. So I am actually serving the northern zone in the Republic of Maldives. So Maldives as such is a very unique land that is 99.9% water and geographically very much separated by the sea. So we were actually had the opportunity to launch our department on this particular specialty in the northern zone as such. So before going there 3 years ago, the situation was that if one had to take out a tooth or surgically do a disimpaction, one had to either rely to go to the capital to get it done. So it was indeed a difficult decision for me to make also, whether to go to a higher center, gain more exposure, do more surgeries, or whether to go to this particular part of the world and start up something which would actually benefit the mankind there. But actually after 3 years of serving in this particular country and this particular hospital, I can say with this award also, I feel my 3 years has been like fruitful, and almost 72,000 to 75,000 population has been benefited by the work that we are doing. So, and the type of trauma that we get is also unique, like we get sometimes sea traffic accidents, fish bites on the face also. So some things are actually quite interesting in that region as well. So thank you so much, Peripheral Academy, for recognizing the effort that we are doing, and this is indeed that is something that will fuel more work that is going forward. So thank you so much. Thank you, Peripheral Academy, and Mohan and Ashish. Thank you.
The outer in periodontology goes to Dr. Bennett Aloysius Fernandez.
Thank you, sir.
Thank you. I feel really honored and at the same time very humbled receiving this award here at Sri Lanka. I've come all the way from Malaysia. Would like to thank Dr. Ashish Chandra and also Dr. Anmol Bagaria. I've been associated with Cynodent from a very long time, and it feels really gratifying. I've completed more than 20 plus years, and as you saw in my keynote, the importance of prevention, keeping God-given teeth, and that's the essence of perio. We are progressing slowly in perio more towards placing a lot of implants, but even that requires a lot of care. So with that, I would like to say thank you, and I also would like to congratulate all the other fellow PFS who have been there. Keep up the pledge. and congratulations to all the other awardees. Thank you so much.
Award goes to Government Dental College and Hospital, Nagpur, Maharashtra. The International Best Dental Institute Award goes to Sharad Power Dental College and Hospital, Maharashtra. Maharashtra, I'm sorry.
Oh, one more, sir.
Once again, I'm getting the opportunity to stand in front of you, and I'm representing the college, or my college, that is Sharad Pawar Dental College. Unfortunately, our dean, Dr. Manoj Chandak, was supposed to receive this award, but he authorized me to receive on the behalf of Sharad Pawar Dental College. Our college is striving hard to come to the level that we achieved a very good NIRF score in last year, and our institute has really been doing such a great work for all the undergraduate students, postgraduate students. We are running so many courses at our institute, and also community health programs are getting tremendously done. We are very much enriched with, and every student is contented by doing so much of clinical work and research work, and we are getting, including faculty as well as students, getting opportunity to always stand better, and the college is there to support us, guide us, encourage us. There is nothing, no time I could find that I have been discouraged, and to tell you that I am in this college since more than last 22 years, and therefore I feel that our Sharad Pawar Dental College really has achieved today at the international platform, and that too PRA Fortune Academy Award, International PRA Fortune Academy Award. Getting to Sharad Pawar Dental College is the best decision by PRA Fortune Academy. Thank you so much.
Dental Institute Award goes to Bapuji Dental College and Hospital, Davangere, Karnataka.
Sir.
Very happy good afternoon for all the visitor delegates and participants over here. I am Dr. Nandishwar, DD, Principal of Bapuji Dental College and Hospital, Davangere, Karnataka. I am very happy that PRA Fortune Academy has recognized our institution as the best international dental college for academic excellence. I would like to thank all my support system, my chairman, faculty and other staff members for achieving all this goal of educator in the field. To brief about my institute, our institute has started way back in 1979 as a second private dental college in India, and over the 45 years we have achieved many laurels in the field of dentistry. All across the globe our alumnus have spread, and they are all doing very well in their field, every field. And more than 75 institutions across India are headed by our alumni. This itself will tell you regarding our institute, how it is doing. So I thank you, Dr. Anmol, Dr. Ashish, and PFA Academy for recognizing our institute for this prestigious award. Thank you, one minute.
What goes to Yenapoya Dental College, Karnataka.
Okay, sir. Okay, sir.
Thank you.
Good afternoon, ladies and gentlemen. It gives me an immense pleasure to be here today. At the same time, sort of a responsibility for our college got this particular award. I thank each and everyone, those who are responsible for this, right from the beginning, from the sweeper till the head of the department to the teachers, the students, the postgraduates, and the management given us a facility to achieve this particular goal. I thank all the stakeholders for having faith in us to do these particular activities. At the same time, I thank the PFA Academy to giving us a platform to excel. And it increases our responsibility even more after getting this award. Thank you so much.
Once again, the Yenapoya Dental College received this International Best Dental Education Institute. I thank all the organizing team, especially Dr. Anmol and Dr. Ashish, who has taken this step to recognize us. Now, to tell about Yenapoya Dental College, we are established since 1992 onwards. We are in the education field. The university had earlier only one dental college. Now we have 11 institutions at the Yenapoya University, and we do our best for our education system. And thanks to all the team who supported to get this award. Thank you once again.
Naya Hospital, Nair Hospital Dental College, Mumbai, Maharashtra.
Okay, sir.
A very good afternoon to each and every one of you here. Believe me, it gives me great joy to get this award for my institute. My institute, Nair Hospital Dental College, is 91 years old. It was established way back in the year 1933 when we had only 6 dental chairs. And today we have more than 310 dental chairs and 2 big building skyscrapers amounting to a total of 25 floors. Myself, Dr. Neelam Andrade, I'm a maxillofacial surgeon. I'm the dean of this institute and also the medical director of all the BMC hospitals in Mumbai, amounting to a total of 21 hospitals. So it really gives me a joy that our institute has got this International Best Dental College Award, and my particular gratitude to all the doctors, to all the students of my hospital, to all the nursing staff and the labor staff. Together we treat about 3 lakh patients in a year, amounting to almost 1,000 to 1,200 footfall every day in 9 dental specialities. I have one of my professors here, Dr. Trupti, I request her to join me in also getting this award for the institute.
Okay. Madam, thank you.
Best Dental Institute Award goes to Bharati Vidyapeeth Dental College and Hospital, Maharashtra.
Okay.
Very, very good afternoon to all present here. I am Dr. V. Srinivasan, Principal of Bharati Vidyapeeth Dental College in Bombay, Navi Mumbai, Bombay. At the outset, I would like to thank the PFA Foster Academy section at large, especially the chair and co-chair, Dr. Anmol Bagaria, Dr. Ashish Chandra, and of course the Sri Lankan representative, Dr. Udaya. It was wonderful to be here to receive this prize on behalf of my college. And it's really wonderful that they are bringing together the countries of India and Sri Lanka. So I really congratulate all of you over here. As you can see that India has many wonderful dental colleges. And our claim to fame is that we are one of the youngest of the block. We're barely 20 years old. But in spite of that, we are here receiving it, and we are really grateful for this recognition conferred on us. We are a part of a university which is a NAC A++. NAC is something like your quality, international, how you have assessment of, for those of you who are here in Sri Lanka. So we are a part of a university which is NAC A++. We are the first dental college which has got an NABH accreditation to its hospital services in Mumbai. And we are one of the few in the country. We have been getting innovation prizes at the Global Innovation Conclave at Delhi for the 2 years consecutive, because we have about 30 patents we file almost every year. We are a college which produces at least 50 Scopus publications every year in the last 5 years. We are also having a lot of innovative courses for our students, including specific practice management modules and research modules for our students. So we offer a world-class infrastructure with smart boards and all other conveniences for teaching. And we hope to use this award as a springboard to continue to excel and be recognized by our peers. I thank the management for trusting us and supporting us, and all the faculty members and the students for helping us reach this position. Thank you very much.
The international best goes to Faculty of Dental Science, King George's Medical University, Uttar Pradesh. Lucknow, Uttar Pradesh.
Closer.
Good afternoon, everyone. Myself, Dr. Nandal, Professor and Head in the Department of Odontology, King George's Medical University, Lucknow, India. I thank to all the PFA officials, especially Dr. Anmol and Dr. Ashish, for providing this international fame award to us, and I am really thankful to them. Some other our professor will try to speak.
First of all, a very good afternoon to everyone present here. And on behalf of King George's Medical University and Faculty of Dental Sciences, myself, Dr. Pavitra Rastogi, and I feel proud to be here at this moment after getting this such a wonderful award. And such a beautiful city of Colombo in this beautiful, vibrant country of Sri Lanka. We all 5 persons came from King George's Medical University, and it is a 120-year young university. And the number of patients fallen daily, it's more than 15,000 in our university. And it's a medical university and a dental university. Earlier it was a dental university also. Now we are a medical university, which is a part of Faculty of Dental Sciences. So again, we feel very, very proud to be here at this moment, and we are thankful to the PFA Academy for giving us such opportunity and such award of this by Dr. Anmol Bagaria, who is a section at large, fascia section, and for exceptional excellence in dental education, research and professional training. Thank you so much. Thank you so much, Dr. Anmol and Dr. Ashish. And especially Dr. Uthaya Kumarji from Sri Lanka. We are really thankful to you. Thank you. Thank you.
Service Excellence Award goes to Government Dental College and Hospital, Mumbai, Maharashtra. So Government Dental College and Hospital, Nagpur, Maharashtra. International Community Service Excellence Award goes to School of Dental Sciences, Krishna Vishwa Vidyapeeth, deemed to be in University, Kharad, Maharashtra. Kharad, Maharashtra.
Right, okay.
Good afternoon. Good afternoon. Actually, to say everybody has said that their college is a very old college, but to say my college is a very youngest dental college amongst all the colleges over in India. To say we are only a 13 years old college, where our college has been NAC accredited with an A grade, A+ grade. We have got a community award to say that we are having around 5 villages which we have adopted it. In that 5 villages, we have taken care of all the things, including medical and dental. Everything has been taken care. Whatever the treatment which we are going to offer for 5 villages, we are doing it very free of treatment. Everything will be taken care from our management. So our management chancellor is Dr. Suresh Bhosle. He is an onco-surgeon. The entire thing, the entire payment, everything, whether it is a medical or whether it is a dental, has been looked after by the Krishna Vishwa Vidyapeeth. It is in Karad in the state of Maharashtra. Thank you very much.
Lifetime Achievement Award goes to Dr. Neelam Andrade.
dignitaries on the dais, all the participants, the winners and the fellows in the audience. Believe me, I'm deeply humbled and extremely grateful to Pierre Foucault Academy for bestowing this award on me, to Dr. Anmol Bagaria, Dr. Ashish Chandra, Dr. Uday Kumar and Dr. Wise. This award means a lot to me, especially coming at a point when I'm just about 8 months away from my retirement. To be honored, this is like a cherry on the cake. My institution, Nair Hospital Dental College, was my Gurukul as well as my Karma Bhumi. I entered this institute as a student in the year 1979, and after 46 years as a student, as a teacher, as the dean and the director, I'll be leaving my services this year end in December 2025. I've had the privilege to teach, to learn and tutor 37 postgraduate students. I have 8 PhD students under me. I have my faculty with me, almost 62 of them. It's been long years, but through this institute and through BMC, Brihan Mumbai Mahanagar Palika, which supports our college, I have earned this title after working as an oral and maxillofacial surgeon. I have contributed more than 100 publications, more than 300 keynote talks, tutored my postgraduates, pioneered in the field of temporomandibular joint ankylosis, orthognathic surgeries, distraction, osteogenesis, submucous fibrosis, trauma and other pathologies. It has been very gratifying, the entire journey, for which I thank BMC, I thank my late parents, I thank the Almighty, and I dedicate this award to my family and my students and my staff, my non-teaching staff who helped me in this long journey. Thank you so much. Thank you for giving me this honor.
Lifetime Achievement Award goes to Dr. Shashi Kiran, MD.
Hey, thank you, sir.
Good afternoon once again. I have been awarded for this award, like a Lifetime Achievement Award. To say few points about me, I have been graduated from esteemed Bapuji Dental College in the year 80. I joined in 85, I finished on 90. And then my teacher is here, Dr. Shambat. He used to teach me about a pedodontist. I am actually a pedodontist working in Karad once again, School of Dental Sciences, Krishna Vishwavidyapit, Karad. So, my brief introduction, I am right now holding a post of a president in Indian Society of Pedodontics and Preventive Dentistry. I am a fellow ISPPD, I am a star pedodontist of ISPPD, I am a young pedodontist award of an ISPPD. My publication is roughly around 150 plus publications. All are in Scopus, PubMed and so forth. Q1, Q2, Q3. I have around 40 patents, maybe around 100 copyrights. This is my achievement of my own personal things. This is all because of, once again, I can say OV2 and Bapuji Dental College, and the People's College of Dental Sciences, Bhopal, and then the School of Dental Sciences, Karad. With this brief introduction, thank you very much for Dr. Uday Kumar sir, Anmol sir, and Ashish Bagaria for giving me this prestigious award. Once again, I'm giving you a thanks to Imperial Featured Academy to give me this chance to get an award. Thank you very much.
Lifetime Achievement Award goes to Dr. Vasundhara Professor Dr. Abe N. Datakar. Lifetime Achievement Award goes to Dr. Laxmikant Chatra.
Good afternoon once again. Me, the Dr. Lakshmikant Chatra, Principal of Mumbai Dental College. I'm Senior Professor in the Department of Oral Medicine and Radiology. I've been a practitioner for the last 32 years as well. Academically, I have 266 publications and more than 50 postgraduates being passed out under me. 3 have got the PhD from our university. At the same time, as an examiner to all over India, more than 70 colleges, as an examiner for both postgraduate and undergraduate exams. I am the paper setter for the exit exam for the NBE, National Board of Examination, as well as for the NEET, as a subject expert in the oral medicine radiology southern region. And this gives me an immense pleasure to be here on this dais by getting this award. First of all, I should be able to tell that I should thankful to my family and my parents for giving me a good education. At the same time, my family has given me an opportunity to dedicate myself to the dentistry. I've started my career as a tutor. And each and every designation what Dental Council of India states, I have gone through the same thing. From the assistant professor to the reader, associate professor, professor and head, vice principal and a principal. I'm got retired, superannuated a year back. I'm on contract basis as a principal. Since then, I think this particular award, what's been given by the PFA Academy, instills at the same time, gives me a responsibility to go ahead with my activities the same gist as I have all these years. I'm thankful to my academy, the Indian Academy of Oral Medicine and Radiology, wherein we have conducted 2 times the conference in Mangalore, 2010 and the 2014 and the 2024 last year. And at the same time, we had a good time with the older oral medicine people around us, and recognized one of us among us is already there, Dr. Srinivasan. I thank each and everybody, all the senior members out here about the age of me. I'm thankful to each and everybody. They made it possible for this particular function where the achievement is being given an importance. And PFA, a heartfelt thankful to the PFA for this particular gesture, and my responsibility increases here on. Thank you so much, ladies and gentlemen.
Card. International UG Student Merit Award goes to Sagar CA. Student Merit Award goes to Radhika M. Poojar. International UG Student Merit Award goes to Anujna B.M. International UG Student Merit Award goes to Aditi Mahesh Gandavar.
Sir, excuse me. Okay, sir.
The Student Merit Award goes to Ekta Jian Lahoti. International UG Student Merit Award goes to Karan Shahi.
Okay.
International UG Student Merit Award goes to Bhushan Chandra Pradhan from Nepal.
Okay.
Merit Award goes to Radhika M. Pujar. International UG Student Merit Award goes to Ekta Jian Lahoti. Okay. International UG Student Merit Award goes to V. Abhirami. International UG Student Merit Award goes to Yashasvi Singh. International UG Merit Award goes to Nimisha Kumari. International PG Student Merit Award goes to this is the International PG Student Merit Award in the Department of Prosthodontics, Dr. Akansha Sanjay Khatkade. International PG Student Merit Award in the Department of Prosthodontics goes to Dr. Harman Deep Daliwal. International PG Student Merit Award in the Department of Prosthodontics goes to Dr. Akansha. This is a kind reminder for all of you. There will be a photograph of the award winners at the end of the session.
Excuse me.
The Department of Oral Medicine and Radiology goes to Dr. Shweta Viradrinath. International PG Student Merit Award in the Department of Oral and Maxillofacial Surgery goes to Dr. Raina K.M.
Okay.
PG Student Merit Award in the Department of Oral and Samiksha Gaur. International PG Student Merit Award in the Department of Oral and Maxillofacial Surgery goes to Dr. Abhijit Humne. International PG Student Merit Award in the Department of Conservative Dentistry and Endodontics goes to Dr. Manasi Suravade.
Okay.
Nikhil Purohit. International PG Student Merit Award in the Department of Periodontology goes to Dr. Shraddha Ramesh Jadhav. International PG Student Merit Award in the Department of Periodontology goes to Dr. Olirmati alias Vinodini. International PG Student Merit Award in the Department of Periodontology goes to Dr. Danish Sania. International PG Student Merit Award in the Department of Periodontology goes to Dr. Jisha S. Raj. International PG Student Merit Award in the Department of Periodontology goes to Dr. Pooja N. International PG Student Merit Award in the Department of Periodontics goes to Dr. Arya M.
Close. Ah, yeah, fine. Okay. Yes.
Good afternoon, everyone. I'm Dr. Preeti Shinoy, pediatric and preventive dentist and alumni of Yenapoya Dental College, Mangalore, Karnataka. I'm really honored and privileged to be receiving this award, International PG Student Merit Award, from the Perry Fushire Academy in this beautiful country, Sri Lanka. Not to forget, I'm grateful to Almighty, my parents, my family, and my spouse who's here. And also my gurus, the HOD, Dr. Sharan Sargod, my guide, Dr. Ajay Rao, and my other teachers, and two of them are here, Dr. Shyam S. Bhatt and Dr. Lakshmikant Chhatra sir. I'm very grateful. Thank you so much, everyone. Thank you.
International of Periodontics goes to Dr. Devala Raju Megana. International PG Student Merit Award in the Department of Periodontics goes to Dr. Shravya N.
Okay, doctor. Okay.
Goes to Dr. Tanhaz Kareem. International PG Student Merit Award in the Department of Oral and Maxillofacial Pathology goes to Dr. Monica Katruba Kajalkar. International PG Student Merit Award in the Department of Public Health Dentistry goes to Dr. Mahalakshmi HS. And that's the end of the award ceremony. Thank you, ma'am. Thank you, sir. To come. All right. All the fellowship receivers, all the fellows to come up on stage for the group photograph first.
Good afternoon, everyone. We welcome you again to the 16th World Dental Sciences and Oral Health Conference. Now, we are continuing with the post-lunch sessions. The first lecture is of Dr. Arunesh Kumar Tiwari, sir. He will give lecture on the medical emergency in clinics, in dental clinics. We welcome you, sir.
Good afternoon to all, and welcome to our next session for scientific. And please call your colleague and friend. This is important lecture, and this is the medical emergency is like salt. And in Hindi कहें तो हम नमक हैं, हर जगह हमारा प्रयोग होगा. Salt make every curry, every salty thing make tasty. Any high or low concentration become problematic. It will destroy all the food. So we should aware the medical emergency, what medical emergency may encounter during dental practice in dental clinic. Sometimes we think that medical emergency only it's written in literature, in books, and we never encounter. But believe daily, any dentist, any practitioner is daily encountered with any type of medical emergencies. So we should aware the think how we should prevent this. Prevention, preparation, and then management. If you are able to prevent, nothing better than this. So for better prevention, what you will do, what precaution you will do, some step you should follow, that you have to take proper history. The ABCDE of history is basically involve allergies, history of allergies, bleeding tendency, cardiac history, drug history, and history of diabetes. Second thing, antibiotic prophylaxis. There is very confusion that antibiotic prophylaxis is required in which cases, like which type of cardiac problem. So simple statement is stent and pacemaker. They do not consider for antibiotic prophylaxis. Only prosthetic valve replacement or any valve surgery that require antibiotic prophylaxis. Another problem, people think that if someone is going for extraction, then only antibiotic prophylaxis is required, but not. If you are only probing in periodontology, only probing, you should advise for antibiotic prophylaxis. Third is drug indication, what drug patient is taking. It might be you provide drugs that may be synergistic, antagonistic, so you should aware what drug patient is taking. Obviously, vital sign is very important. What is the baseline? Accordingly, as a dentist, we routinely give local anesthesia. So, local anesthesia have adrenaline, local anesthesia lignocaine is a vasodilator, adrenaline is a vasoconstrictor. So, these two drugs affect the vitals. So, you should aware the baseline of the vital sign. And we should follow stress reduction protocol. Everybody knows this stress reduction protocol. Pre-operative investigation is important. Position and meal and sensitivity test. This is very important. What is concerned with position? As a dentist, mainly we have seen the emergency in form of syncope. I think everybody have seen the syncope patient in the dental clinic. One day I asked, actually in King George Medical University, we operate, myself maxillofacial surgeon, we operate the cases on table in local anesthesia, and in exodoncia clinic we do minor surgery like extraction. And I observed that local anesthesia is solely not culprit for the syncope. In exodoncia clinic, we found almost 2 or 3 syncope patients every week, particularly in summer season. But in local anesthesia clinic, where we operate long maxillofacial cases in local anesthesia on table, within a year, when I observe collect the data, within a year, no syncope patient we have observed from the local anesthesia clinic. Then I thought, what is the difference? Exodoncia, the same season, all summer and all this season we have collected data. So what is the particular difference between exodoncia clinic and local anesthesia clinic, where we are using same local anesthesia? So the main culprit is position. In exodoncia, the patient position is sitting position. And in local anesthesia clinic, where we operate maxillofacial trauma cases, in lying position. So what we can do to avoid the syncope? Any suggestion? Let us wake up from a nice lunch and you know, any other thought? Yes.
Put in supine position.
Put in supine means?
In a supine position. Patient should be in a supine position. For the
yes. Always give local anesthesia in supine position. And if the vital is stabilized, then you change the position. Believe this, you will reduce the syncope or this unconsciousness number 0. This is my experience, not experience, this is a database evidence. So position is important. Meal, obviously meal is important. Morning session, patient is diabetic or he has taken some oral hypoglycemic or insulin. Without breakfast, he came early morning, and you don't take, you have not taken the history. So it's important relation to hypoglycemia. Sensitivity test is also very important. Particularly sensitivity test, what we do, we take the same local anesthesia and use intradermal to make a bleb and think that we have done the sensitivity. But believe this amount can be cause lethal sequence. This small amount can cause severe anaphylaxis. The sensitivity test, what we have to do? Make a dilution. 1 ml lignocaine with 9 ml normal saline. This 10 ml solution, by this 10 ml solution you use for sensitivity. Then it will give very mild reaction so that you can save the patient from anaphylaxis.
A person who is already allergic. No, I'm not saying.
And what is preparedness? Hello? We should prepare from all the medical emergency drugs, equipment, and obviously training is important. What we have to do if any unconsciousness or any emergency occurs, where is medication, what we have to do, where is oxygen, everything should be labeled so that anybody can pick the drug. And most important thing is, keep always the telephone number of emergency service, and it should be printed or pasted over the clinic many places, and every person or every staff must know these number. If you are encounter with any emergency, you are dealing with emergency to manage the emergency, but somebody may call these emergency number to get timely support. This is very important. We know the technique of IM, IV and all this, but sometimes it's very difficult to give injection over deltoid or gluteal region when patient is not cooperative, particularly epileptic, or patient is having muscular contraction, not cooperating. Then it's a very easy step. You should prefer these lateral thigh position, mid-lateral thigh. You can give injection directly here. So in emergency, the site is slightly changed.
Best choice, pedia patients best.
Yeah, definitely. This is easier to give. Let us discuss the few medical emergency what we encounter. Anybody in the audience have encountered any emergency ever?
Too many times.
Too many. I think everybody have seen the syncope is very common.
Not only syncope.
Not but we always treat like syncope any unconsciousness. The causes of unconsciousness is not only syncope, hypoglycemia, postural hypotension, acute adrenal insufficiency, hyperventilation, MI, epilepsy, cardiac arrest. Almost 7, 8 or 9 medical emergency, cardiovascular accident, all this. So we should able to differentiate these emergency. So what will we do if we try to manage the syncope? At what extent we will try to give the therapy for syncope? Okay, patient get unconscious. We know what is syncope. Everybody knows syncope. So I'm not going to detail syncope. How we will manage? we change the position, try to stimulate respiratory center by aromatic ammonia, but still patient is not revived. Then what we will do? How many times we will wait? Is there any policy for wait and watch? Yes. If we cannot revive the patient within 20 minutes, there is other than syncope. You must think other option.
20 minutes.
20 minutes. Must take water. So this is basic rule. You try for 20 minutes. If more than 20 minutes, always think other option. What other option may be? Second most common is hypoglycemia. If you have taken history, patient is diabetic, or patient have not taken anything, any meal, any breakfast, then you should cautious about the hypoglycemia. So actually we will take up all separately. Important thing is syncope. I left. What is difference between syncope and seizure? Sometimes patient become unconscious and we are not able to identify that is syncope or seizure. So important step is to identify eyeball. If eyelid is closed, eye is closed, syncope. Eye is open, seizure. Eyeball is rolled vertically, syncope. Eyeball turned laterally, that is seizure. First muscular contraction, then unconsciousness, seizure. Unconsciousness, then muscular contraction, syncope. So few feature you can identify this is syncope or seizure, and accordingly you can manage the cases. And postural hypotension is again problem when we try to complete our treatment and ask the patient to stand up. The patient may fall due to hypotension. So how we can avoid this hypotension? So if we monitor patient systolic and diastolic pressure, and there is a difference between systolic pressure more than 30 mmHg from lie down to standing position, and more than 10 mmHg difference in diastolic pressure, there might be chance of postural hypotension. So in that patient, we should aware that patient may directly not come in standing position. From sitting position to lying position to some sitting position, and after some time patient can stand. So by this you can avoid the
like this or in that
postural hypertension. What is hyperventilation? Anybody have seen the hyperventilation?
Okay.
See? Have you seen hyperventilated patient ever? No. No. Everybody have seen hyperventilated patient. When you run for a distance and stop, what you do? This is hyperventilation. Everybody have seen, no? Everybody has seen. So this is body reflex mechanism. When we continuous run, we utilize oxygen, means inspiration part is more, expiration is less. So there will be accumulation of carbon dioxide. So body reflex mechanism to reduce the accumulated carbon dioxide and to make clear these overload of carbon dioxide, body purposefully hyperventilate. so that carbon dioxide may get out. Actually, we feel carbon dioxide is like villain. It's only negative fact, like means ki what carbon dioxide role. Actually, carbon dioxide has very important role. It causes cerebrovascular dilation. Cerebrovascular dilation, and it controls pH by combining H2O CO2, H2O CO3, H plus SCO3 minus. This H plus control pH, and by making control of pH, the calcium metabolism affected and muscular contraction affected. So if there will be loss of carbon dioxide, there will be vasoconstriction of the cerebral blood vessel and muscular contraction, twitching, tremor. So in that scenario, when you are stop your running and standing, body purposefully hyperventilate and remove the overload of carbon dioxide. In the same condition, sometimes patient sitting on the chair and the stress level, brain perceive the same stress level, and if patient is apprehensive and anyhow, sometimes brain perceive the same stress level. So at that scenario, stress, anxiety, tension cause hyperventilation. Means patient start breathing like, and after some time patient become unconscious. What will happen? There is no accumulation of carbon dioxide. So by this hyperventilation, the normal level of carbon dioxide is decreased, expel out. There is no accumulation. So if there is no accumulation, the normal carbon dioxide expel out. Means there is deficiency of carbon dioxide. So there is no vasodilation in cerebral blood vessel, and there is disturbing calcium metabolism and muscular contraction. So cerebral vasoconstriction cause less oxygen, less glucose in brain, and unconsciousness. And nature best ways that nature provide ki the difficult emergency can be managed without any drug. How you can manage this hyperventilation? Rebreathe your extra carbon dioxide. You can use your palm or paper bag. Next, hypoglycemia. The important mnemonics is he is tired. What symptom you will observe? Headache, irritation, sweating, tachycardia, irritability, restlessness, excessive hunger, dizziness. What will you do if a patient is hypoglycemic? You observe that patient is hypoglycemic. You have some history that patient have not taken much meal, and or patient is on oral hypoglycemic. Then you think that there might be a hypoglycemia. So you can use sugar cube over the tongue, or there is availability of, if you are not able to provide dextrose 50%, 1 mg glucagon IM IV, then you can give this. This is a nasal powder. You can glucagon nasal powder. You can put some powder over nostril. That will give the same effect as glucagon. So easy step. Always keep in your clinic. That will provide better result. What is acute adrenal insufficiency? We have learned so many times in UG, PG, if patient is coming with 30 mg steroid, we start our treatment after double the dose. Everybody is using their mobile. Is it? We have heard, no? If any patient is on steroid, you have to do some dental treatment. You start to double the dose and then do your treatment. Everybody read this, but there is problem. There is some lacuna in these lines. Means a patient is taking 10 mg prednisolone, what will you do? There is a rule of 20, rule of 2. If patient is taking 20 milligram of cortisone for 2 weeks within 2 years, that patient is steroid dependent patient. Rule of 2. 20 milligram cortisone for the continuous 2 weeks within a 2 year. That is steroid dependent patient. At that scenario, if you are going for any minor surgery, you have to do double dose of steroid. But the problem is, here is problem. It is written 20 mg of cortisone. I asked the question, if patient is taking 10 mg prednisolone, will you do double dosing or not? Anybody student new or PG student or some excellent awardees in PG and UG? This is question of UG, PG all. Will you do double dosing or not? Yes. 10 mg prednisolone. Sir Nipula, yes. Anybody? But that not follow the rule of 2. That is not follow the rule of 2. There is 20 milligram. It is written in book. But believe, even I notice many after many years. This is 20 mg cortisone. 20 mg cortisone is equivalent to 5 mg prednisolone, equal to 0.75 mg dexamethasone. So if patient is taking more than 5 mg prednisolone, not up to the 20 mg, still he is steroid dependent. This is 20 mg cortisone. 20 mg cortisone is equivalent to 5 mg prednisolone, equivalent to 0.75 mg dexamethasone. What is the difference between these? Dexamethasone is a long-acting steroid, prednisolone is an intermediate-acting steroid, and these are cortisone is a hydrocort is a short-acting steroid. So there is a difference between those. But we know the only thing that what comes in MCQ, like if patient is having 30 years, just double the dose and okay, we have done it. So this 20 mg hydrocortisone is equal to 5 mg prednisolone and 0.75 mg dexamethasone. Acute asthma is also very common. In clinic, stress, anxiety, tension, body release catecholamine, and that cause release of excessive acetylcholine release in the, and that cause the bronchoconstriction. And within LA, if we are using LA with adrenaline, there's sodium metabisulfite that commonly cause allergic response. So if you take history and patient told there, yes, I have a history of allergy, sometime packed food item, or some fruit like I cannot take the apple taking from market because it's allergic to me. Is it something significant to your perspective? Yes. In packaged food, packet of food, there is a use of sulfur, these metabisulfite as an antioxidant, as a bacteriostatic agent. And methyl paraben is also used to spray on fruits as a preservative. So that allergic might be alarmed you, that patient might be allergic, and if the patient is asthmatic, your drug might be lethal for them. So you should concern these things also and plan your patient. What patient is medication is taking, advised to keep with there. And if you are able to provide, give this albuterol sulfate, and here these PZ heller comes, you can keep in your clinic, and 2 puff inhaled is sufficient to stop acute symptom of asthma. What is we will discuss vascular accident later. What is different between angina, MI, heart attack, and cardiac arrest? Is it clear, everyone? What is angina? What is MI? What is heart attack? And what is cardiac arrest? Actually, it's not necessary to know all the mechanism, but what benefit we can get from just just brief knowledge of differentiation only. We can call someone that patient is having cardiac arrest. It is very short conversation. Otherwise, what you will say, patient is not responding, respiration is very low, and heartbeat is very low, is almost nil. So another person, emergency person, will assess what will happen. And if you are able to identify the patient is suffering from which problem, one is you will communicate that patient is MI. Please come some ambulance and emergency services. So at least our level we should be very clear about what is angina, what is MI, in layman heart attack or cardiac arrest. What is angina? Angina is a pain of MI. Choking, crushing pain over chest is a pain of angina, or left arm, left lower jaw. The pain of MI is angina. Pain of MI is angina, but all angina is not MI. Confusion? Okay. If pain of MI, that is angina, persists more than 30 minutes, is MI. Clear? The pain of MI is angina because it's a crushing, choking pain. If this pain persists more than 30 minutes, this is MI, myocardial infarction. And this is cardiac heart attack, not cardiac arrest. It's heart attack. In layman, if someone saying that patient is having attack, that is MI. And it's many times it's not very emergency, but only patient may become unconscious because some part of the cardiac muscle is not getting supply of the blood due to formation of thrombus in the coronary artery. So that part, that muscle of the cardiac is not contributing in the contraction of the heart. But still there is a cardiac output, obviously low cardiac output, so there will be less supply of the blood and glucose and oxygen to the brain, so patient may be unconscious, semi-conscious. So the treatment is very simple. What is treatment? Treatment is sorbitrate. Everybody must keep at their clinic, even their wallet and home everywhere. We must keep sorbitrate, heart-shaped tablet, heat sublingually, it will resolve the problem of MI. MI is not a big problem. MI is not immediate emergency, not in emergency like a minute. But cardiac arrest is a problem of emergency. It's severe emergency, and we have seen in the recent year someone is playing and fell down, someone is bowling and fell down, someone is sitting and reading and fell down and collapsed. So the cases became so prevalent. So everybody must know these differences. That's why I skip all the thing and come at that point. Otherwise, the people are sitting very less, and these people may not get lost. So that I skip. So cardiac arrest is very prevalent in recent year. So we should aware. It's a God bestness that the disease which is very lethal, the treatment is very easy. Nothing medication is required. In MI, there is requirement of medication. That is sorbitrate. Or any vasodilator you can give. But sorbitrate sublingually is very easy, and anybody can put on. If you suppose that it might be MI, and you take sorbitrate, nothing worry. It's not very harmful. Okay, you just suppose it might be, even you can use it. So it's not dangerous. Cardiac arrest is important. What is cardiac arrest? The myocardial infarction is a vascular problem. There is an obstruction of the vessel, so that part of the cardiac muscle is not getting blood supply, and that part is not contributing to generate cardiac output. But cardiac arrest is a problem of electrical. Cardiac arrest is an electrical problem. What is electrical problem? SA node, AV node getting the nerve supply and controlled by various nerves to control the contractility of the heart muscle. If this contractility and rhythm disturb, there may be ventricular tachycardia, ventricular fibrillation, ventricular or atrial fibrillation. What is this fibrillation and there is excessive increase in heart rate. Means that what is normal 70 to 90 or 80 to 100 type. Okay. Then the heart rate will be more than 300, 400. The heart will contract like tremor, like this, and no any contraction pressure generate. So the cardiac output will be zero, almost zero. And if the blood supply of the brain is less or lost for 3 minutes, maximum up to 6 minutes, patient will die. So this is actual emergency. We have to well trained to do CPR. Effective CPR is work of practice. If we are not able to generate effective pressure and we are not able to depress the rib, sternum more than 5 centimeter, actually we are not providing the CPR. Only we are doing the work as far as our satisfaction. So effective training is required to manage the cardiac arrest, and the basic thing, this is very prevalent, so we all should be trained to do CPR and identify the cardiac arrest patient. There will be no respiration, no pulse in cardiac arrest. Start CPR and 30 is to 2 breathing, 30 compression. Recent studies says if you are not able to do breathing, Only compression is sufficient to start the heart. Okay, due to constraint of time, I finish this lecture. Last DCA RAM kit. Everybody should keep these drugs in their clinic, in their home. Every elder or distant person must keep it in their medical kit. Ecosprin 75 mg for thrombolytic action. Rosuvastatin is an anti-cholesterol, anti-lipid action. And obviously sorbitate 5 mg, 1 tablet. Thank you very much. Okay. Otherwise, I can continue to.
Dr. Ashish Chandra on stage. And Dr.
Thank you. Sir, okay. Yeah, look at the camera. Yes, sir.
Okay. Good evening, my dear colleagues, my special Sri Lankan colleagues and my Indian colleagues and your Prime Minister as well. I didn't get a chance to welcome your Prime Minister yesterday, so thank you for giving me an opportunity. He's going tonight. I hope you will stay back 2 more days and go a little later. So that's me. And the topic says graftless management of thin ridges. Though I say graftless, I'm showing a few cases with graft and I'll tell you how to avoid grafting. And I'll try to go fast because I know everybody wants to go and you're doing me a favor by staying here. But by any chance, if you want me to go a bit slow, just let me know. So when you are going to place an implant, you have to have adequate bone. In the ideal world, when a company does a course, there is always adequate bone. But you go and sit in your clinic, you don't get enough bone. And you have compromised bone situations where there is vertical bone loss, horizontal bone loss, and vertical and horizontal bone loss as well. And what is the adequate number? When I say adequate implant, you have the magic number. The magic number is 1, 2, 3, 5, 7. I hope everybody knows this number. 1 is buccolingual ridge to the implant, 2 is from a wider structure, 3 is from an adjacent implant, and 1.5 is from the adjacent tooth. That is the magic number you should remember if you are doing implants. And what is 5 and 7? Is the prosthetic space. From your crust module of implant to the opposing occlusion, if you have 5, you give a screw retained prosthesis. If you have 7, you give a screw retained or a cement retained prosthesis. 5, you cannot give a cement retained. So basically 5, you can give only screw retained, 5 and cement or screw retained. So vertical bone loss, there are many ways of doing it. And again, horizontal bone loss, you can do block grafts, particulate grafts, osseotraction, bone expansion and bone splitting. Out of this, I'm only going to talk about bone splitting. Why do we have to expand the bone? Because we always think if you can just put it in implant, you can give a teeth. But what we want is a perfect aesthetics, good emergence profile. To get that, you have to have a wider implant. So if your implant is not wider, this is how your emergence profile is going to look like. Your implant will stay, but it will not be a case that you can show to your colleagues proudly. So the decision maker is not distal, decision maker is not bone width, it is the mesiodistal space. Most of the time what we do, we measure the bone width and decide on the size of the implant. But at least in the anterior region, it should be mesiodistal space and not the bone thickness. So these are some measurements, I'm not going to read it for you. So once you do an extraction, within first year you will have 25% bone loss, and then continuously you will have 30 to 40% bone loss in the next 3 years. And where will you lose the bone? More buccally, not palatally. So buccal bone loss is more, and that is the place where you get aesthetics. So these are some literature to say that the buccal bone will be lost, and again some literature. And why are we going to do expansion? Because it's cheaper, quicker, and you don't know other expenses. So basically I don't even tell my patients I'm doing an expansion. I just go ahead. So what does the history say? From 1980s onwards, they have been doing bone expansion. So it's not something new. So this will be my lecture path. So this is the procedure I'm going to talk about. Put a more parallel incision, go with a smaller drill, and no more osteotomy, start expanding with expansion screws. Different kits are there providing it. Mr. Curate gives a kit, and Dentium has a kit, and Ostem has a kit, Biohorizon has a kit, so you can choose anything you want. If you feel it's expensive, Jalandhar also has it. So that's it, you could see the bone moving buccally. So without any graft, we were able to place the implant. Let's see a real life case. A 20-year-old girl walked into my clinic, have lost the tooth a few years back. And this is her. And I just raised the flap and measured the thickness, and thickness was very less, around 3 millimeters. I raised the flap and I could see. Can you see this margin here? Both the cortical plates meeting each other, so that means I could spread the bone through that. So that's my surgical stent, where I place my implant through that. It's not a fully guided stent. It is a non-limiting stent. So my first drill goes in, X-rays, and this is one thing that is very nice to do. Onto that osteotomy you do, please use those economically effective probes and expand it. Please don't use those expensive hoof-ready instruments. You buy those 15 rupees, 20 rupees probes. When you started your clinic you bought, take them, push them in, they will work as very good expanders. Just expand it, and these are the expansion screws. You go on with it. They are color-coded, white, yellow. Go slowly, no hurry, not like I am lecturing. You have to do it slowly in the clinic. And then if when it fractured, I use the BP blade to spread the bone so that the bone relaxes a bit. And the final expansion done, up to blue. Then I place a 4.2 implant, checking the directions, looks fine, done. But I have created a labial fracture there, so I have to do some grafting. Little bit of contour grafting. I'm not increasing the bulk, just protecting the soft tissues there, a contour augmentation and membrane placement. Sutured, patient goes home, comes back after 6 months. That's what I got. See the bulk of bone I have got. Now I cannot even see the bone, see the implant, because it's all bone there. So I expose the bone and I can see the implant, and that's the results even after 15 years. See the margin. See the emergence. It's all kept just because I took 20 minutes more when I did the implant. So that's after 15 years. So when expanding mean width ridge of 3 millimeters, you will get about 5 millimeter. So you are getting about 60% gain. The maximum amount of ridge expansion was observed to be 83%. And this is the most important thing. When you do the expansion, you get 42% and later you get 57% because of the biological process. Any bone graft you put, you will see some amount of bone graft getting resolved. But if you do proper expansion, you will see bone gain there. And that is without any cost. If you don't want to do any augmentation procedure, of course you know what to do. So this is the most important thing in my lecture. If any youngsters are there, they can take a photograph of it. The ridge size should be between 3 millimeters to 6 millimeters. If you want to expand, and if it is less than 3, don't try to expand. And also there should be some cancellous bone sandwiched between 2 plates. The 2 conical plates, in between you should have cancellous bone. And it should be D2, D3 or D4 type of bone, never D1 bone. Thank you. So this is the kit I used to do, Mr. Curate kit. This is not expensive, within about 25,000 or 30,000 Indian, it should be. When I bought it was 2012 I bought, when it was like 12,000 Indian, I don't know the price now. So it's all color coded here. So you can, according to the color code, you can keep on expanding and slowly do it. If you are an OMF surgeon and you're fond of hitting and meloding, you also can use this type of a kit. But when you choose the kit, make sure it has a stopper. So with the expansion kit when you buy, you have to buy something else also. That is, any standard implant kit will give you a drill of 2 millimeters. I said, if you want to expand, the bone should be minimum 3 millimeters. If you drill a 2 millimeter drill into a 3 millimeter bone, you are left with 0.5 on both sides. So you can't expand. So invest yourself into some smaller drills. These are 1.1 millimeter drills. Please invest yourself into these small drills. At least officially, unofficially speaking, if you don't have those drills, use your interdental burr, aorta. Can it burn the bone? Water is contaminating. Won't it cause an infection? Well, we'll discuss about it tonight after dinner, but not now, right? So if you don't have these drills, at least use an aorta, make a small orifice, and from there start on. How can I do it better? Reduce the flap size, so the blood supply is not compromised, and if you can, use a piece of surgical unit. Otherwise, you could go on cutting the lip of the patient. An accident I had where when I pulled my blade, it cut the patient's lip. So this is another patient, a cleaner by profession, and before wedding she wanted implants and she didn't have much money, so she had no money for grafting. Raise a flap. You can see a small ridge there. And I'm taking access more palatally here. I'm not going mid-crestal, I'm going more palatally. Again, with the probe expanding, using a piece of surgical unit and doing the expansion. So this is how you use a piece of surgical unit. Step by step you go in. A piece of surgical unit blade is less than 1 millimeter thickness. So it's like your BB blade with a vibration. It works like your ultrasonic scaler, but 10 times powerful than a scaler. So your scaler will not do the job. And go on expansion, white, yellow, red and blue. Now you achieve the correct expansion. Very small flap, no vertical incisions. And the last drill goes as to mark the final osteotomy. And the implant is placed, perfectly placed. Just a 3 millimeter ridge. I placed a 4.2 millimeter implant. So I enlarged it up to 6.2 millimeters. So this is she when she comes back for the restoration. From here to here without any grafting procedures. This is after opening exposure. I do agree a little bit of exposure is there, but still acceptable. So this is another patient whom walked into my clinic, a 64-year-old lady. Nothing significant, all options were given, and I said, okay, bone expansion has to be done. She came in, the bone was very thin, only 3 millimeters. So I took my expansion tool, and if you are working in this part of the world, India and Sri Lanka, please buy this expansion kit and keep it. Every patient is compromised of bone. Because when we do extractions, we feel like giving things free. When you buy stuff in our clothes shops, you buy a sari, they give you maybe some frock free. Right? You buy a suit, they give you a shirt free. So when the patient comes to extraction, we do a gingivectomy, alveolectomy free of charge. We are so generous at giving. And then what happens? Bone shrinks. So all the bone is lost. So you should have a kit like this. So the bone was about 3 millimeters, and it's a full arch case. I cannot leave it, so I tried to spread it with a BP blade. BP blade was missing, slipping. So I used a disc type drill to do a vertical osteotomy. I reduced the height of the bone so I could get some wider bone. Then I started expanding. Actually, the pictures are not clear in this. I started expanding, used the same kit, went on expanding. Then I put my first expand the white one in the first osteotomy. Then in the second osteotomy, the white second osteotomy, first expander, and first osteotomy, second expander. So sort of serially I am expanding all my implant positions. Slowly I go. Now look at the expansion I have got. Can you see the plates? We are only 3 millimeters. The whole full arch maxilla was expanded beautifully like this. All 4 implants placed. I got up to 6 millimeters. The full arch case was done. It's more than 10 years. Patient is still happy. So this is University of Peradeniya where we studied. I have the joy of enjoying and telling all my Indian colleagues jealous. That is, education is totally free in Sri Lanka. From grade 1 to PG we get free. Totally free. Right? And when we go to the university, this is our hostel. We stay there. Of course, hostel is not free. We are supposed to pay 150 rupees Sri Lankan a year. That's all we pay. That is to show us that we have to pay for ourselves. To teach us that we should pay. And food is subsidized. Here we stay and study. Alginate, mirror and probe, everything is kept in the surgery. We don't buy alginate, we don't buy plaster Paris. It's all given in the clinic. Mirror, probe, handpiece, everything is sterilized and kept. We just go and start working like surgeons. So that's the standard of education in Sri Lanka. And with all that, if you say, sorry, I cannot afford, my parents are really poor, and you give a letter to the government pays you like 6,000 rupees a month to sit and study there, just for your food. That's roughly around 1,800 rupees Indian per month, and that's more than enough for us to survive in that place per month. So, mandibular ridge expansion using horizontal bone splitting technique. So this is another case which came into my clinic, referred by my good friend Dr. Meghanathan. So this is the amount of height we had, 4.2, nerve was close by, 9.8. So we couldn't do much of an implant. Then we planned the case and we decided to go for one-stage implant. The problem was if I give a two-stage implant, there will be some bone resorption, crusted bone loss. I don't want that. So I choose a one-stage implant. So we did some expansion and I cannot do the expansion with the BP blade here. It's mandible. Maxilla you can do it. Mandible no. Don't try it. Right? So we plan the case. Sorry. And remember, how do I go back? Right. So I started using some circular drills to do a bone osteotomy with the or bone incision you call it, with some circular drills, and then you can use some osteotomes to spread the bone and then start expanding the bone. The problem with the circular drills is, a myth is there that they are dangerous to use. No, they are not. If you are very careful with it, they are not. The problem people take up is, when you go to buy circular drills, they come in different sizes. And they tell you, if you want to do a small area single tooth, use the smaller one, a big area, use the bigger one. Wrong. That's the place where you go wrong. The smaller one is to do the corticotomy, where you cut only the cortical plate. And onto the cortical plate, you keep the bigger drill and then go deep into the cancellous bone. It will never slip. The problem is, you start, because it's a bigger incision, you keep the bigger drill and start, it slips. So it's a very safe tool to use. Don't worry, don't have a fear of using it. Or you can use a piece of surgical unit if you can afford it. I used Densa drills in this case because nowadays, because we work fast, we use Densa drills. Instead of expanders, you can use Densa also, but they are expensive. A single drill is about 8,500 rupees Indian. So I put the bone incision, then use the Densa drills to do the expansion. You can see how they expand. And Densa drills, if you want to expand, you have to use them in reverse mode. Front mode they cut, reverse mode they expand. You can see in the animation the bone is getting expanded. You can see? Right, okay. Let me jump over. So this is the case we got. Can you see I have put a vertical incision there to prevent it from fracturing, because it started fracturing here. And can you see the vertical horizontal cut of the bone? We expanded the bone nicely and we placed 2 implants there. That's why Densa drills, and then you could place the implants. When you place the implants, the animation shows you are using a graft, but you don't have to, because company sells graft. I don't sell graft. You don't have to use a graft that will heal like an extraction socket. No need to put a graft. You put a graft only buccally if your buccal plate is less than 1.5 millimeters. That's the place where you put a graft, otherwise no need. So these are parallel implants, nice and parallelly placed. So you see, like, some of the implant is exposed, it is not exposed. This is the thread level and this is the polished collar area. So this is a 1-stage implant from dentium. Yes, we have touched the nerve. Patient was having bit of paresthesia for about a month. Thank God I escaped. So yeah, you can see the nerve almost touching. This is a 7 millimeter implant, 7 millimeter. So this is what I'm talking about. This is a 1-stage implant. This is a 2-stage implant. So I used this 1-stage implant. Parallel impressions taken. Of course, now we do digital. We don't do these things now. We do digital impressions now, as Dr. Cohen told. Nice and parallel implants. Impressions taken. Bite registration. I don't tell the patient to keep wax and bite, because the wax get distorted. So I make a wax block and put some zinc oxide eugenol impression paste on top. Zinc oxide is non-impression paste on top and tell the patient bite, so I register the bite perfectly. I'm not doing a denture, I'm doing a implant. And this is the final crown that came in. And can you see if the implant was exposed, there should be some inflammation. See the soft tissue, beautiful healing. That is because I used a one-stage implant, not a two-stage implant. See, soft tissue is very with good harmony with the implant. And placed the implant, and patient was very happy. And only complaint she made was the composites were there. I could not put composite because there was no occlusal height. That's the only complaint patient made. Other than that, patient is happy. So that's all. Thank you very much. This is my contact number. If anybody wants, please contact me, especially through WhatsApp. If you have any doubts, you can always talk to me. And thank you very much. Any questions? I don't think so. And thank you very much for the academy and all my colleagues for giving me opportunity, and especially Professor Uday Kumar, who gave me an opportunity and gave me an invitation. Thank you.
Thank you, sir, for that insightful lecture on ridge expansion to achieve successful graftless implant placements. Finally, we have come to the last item in the agenda, which is the valedictory and scientific prize distribution. In order to proceed with that, we'll take a 10 minutes break and we'll be back. And prize distribution. Dr. Manas and Dr. Anuradha Patil for paper, first prize. And all the Arun Suravade and Dr. Anuradha Patil for paper, first prize.
Okay, sir.
Dr. Georgie P. Sakiraya for paper, second place.
Okay.
First place.
Okay, madam.
Dr. Ashish Chandra to propose a vote of thanks. Sir, could you please oblige on stage?
A very warm greetings and a great evening. All the dignitaries, esteemed colleagues, distinguished guests, award recipients and dear friends. It gives me an immense pleasure and pride to stand before you on this evening at the valedictory function of the prestigious gathering, the 16th World Dental Sciences and Oral Health Conference, combined with convocation and award ceremony of the Pavitra Academy section at large Asia region. From the past 2 days, yesterday we have all the scientific presentations, and today we have the lectures, all the awards, everything was done today, which we witnessed as an enriching exchange of knowledge, innovation, innovative ideas and collaborative spirit from across the globe. This conference has reaffirmed our shared commitment to excellence, ethics and advancement in the field of dental sciences and oral health. As section co-chair of At Large Asia region, I am deeply honored to have been the part of this inspiring platform where we not only celebrate academic and clinical brilliance, but also recognize the value of service, leadership, and professional integrity, ideals that the Pavitra Academy has stood for over decades. Today's convocation and award ceremony mark not just a recognition of individual achievement, but a celebration of collective dedication to the patient care, education, and community service. I extend my heartfelt congratulations to all the new fellows and awardees, recipients. You are the torch bearers of our profession's future. Let me also express my sincere gratitude to our organizing committee, speakers, all those who have helped us, Dr. Kumar sir, the speakers, especially our gracious hosts over here in the beautiful city of the Colombo, Sri Lanka. Your warmth and hospitality have made this event truly memorable. As we return to our respective countries and practices, let us carry forward the spirit of collaboration, compassion, and commitment to the highest standard of dental care. Together, we can shape a healthier and brighter future for the communities we serve. Thank you once again. Wishing you a continued success and a safe travel. Thank you, everyone.
We conclude. I'd like to invite Dr. Anmol Bagaria and Dr. Ashish Chandra to recognize the one who has been helping us from behind, Miss Pirashaleen Uday Kumar, Miss Mitushika Tudigaran, Mr. Takshitar Elongavar.
Come to me. Right, good. Thank you.
Thank you.
Okay, yeah. Look at the camera. One more. Okay. Okay, done. Okay, done. Yeah, look at the camera.